Yes, hello. Good morning, everyone. Happy to be among you and really proud to moderate this webinar. So you would ask why the Belgian Association of Healthcare Managers is taking care of this topic. This is really a medical topic and not our domain of expertise. But as you know, the Belgian Association of Healthcare Managers is committed to improve healthcare, to improve management, to bring innovation, and to improve expertise and share expertise. We were asked by the Federal Public Service Healthcare to share this topic with all healthcare executives, because as you know, no plan, no project, even though a medical one, can succeed without the engagement of the top level of the executives. I am a physician, but this is also not my domain of expertise, so I will try to learn and understand what's the message to be taken at the end of this study day. The recent COVID crisis learned us something. We learned that we share our world with other humans and some bacteria and viruses also. So we will speak about bacteria today, which can also be a kind of like a public concern if there is some epidemic to some resistant bacteria. We also like to speak about value-based care, and value means outcome measures and experience measure for patients, but it also means less harm for patients. So when there is a resistance to antibiotics, we harm the patient. And since the beginning of this century, there has been a lot of publications about the harm we can do and the adverse effects that the patients have in hospitals, including nosocomial infections, as we say, with bacteria resistant to antibiotics. So I'm really proud to introduce experts in this era, and we will begin with a small video that Mr. Facon, director of the SPF Santé Publique, so FOD, and the Federal Public Service Public Health shared with us. So you will hear him for like 10 minutes, and then I will introduce every speaker who will present for maybe less than half an hour, and the questions will be addressed to everyone at the end. You can, of course, write questions on the YouTube channel where you are following this webinar, this study day, and I would be pleased to share them with speakers. So let's begin with the video of Mr. Facon, please.
Beste aanwezigen, eerst en vooral zou ik mij graag verontschuldigen voor het feit dat ik fysiek niet kan bij jullie zijn deze namiddag. Dat heeft uiteraard ook te maken met een reeks vergaderingen in het kader van het sanitair crisisbeheer. Dus gelieve mij daarvoor te willen verontschuldigen. Nu, ik vond het toch belangrijk om vanuit de FOD Volksgezondheid en het Directoraat-Generaal Gezondheidszorg een aantal inleidende beschouwingen mee te geven. En laat mij toe om eerst en vooral de initiatiefnemers te danken, de Belgische Associatie van de Ziekenhuisdirecteurs, voor het initiatief dat zij hier nemen om een thema dat ons zeer nauw aan het hart ligt, de hele strijd rond de antimicrobiële resistentie, vandaag ook tot onderwerp te maken van jullie colloquium. Maar laat ons ook niet vergeten dat dat verhaal in een ruimere sfeer kadert en dat we vandaag ook iets anders vieren. We vieren vandaag de World Patient Safety Day en dat is natuurlijk een uitdaging die ons allen ten zeerste bezighoudt om die patiëntveiligheid, maar ook de veiligheid voor de verstrekkers, om dat op een goede manier te kunnen organiseren. En het is natuurlijk geen nieuw thema, hè. Dus het is al een aantal decennia dat natuurlijk de hele kwestie van de patiëntveiligheid hoog op de agenda staat, internationaal en ook nationaal. En dat is ook omdat we weten dat er nog altijd relatief veel incidenten gebeuren, een aantal vermijdbare zaken gebeuren in het kader van de patiëntveiligheid. En dat we natuurlijk daar ook beleid moeten proberen rond te ontwikkelen om dat zoveel mogelijk weg te werken. En dat beleid natuurlijk, dat situeert zich op zeer veel verschillende punten. Dat situeert zich op vlak van beleidsplannen vanuit de overheid, maar natuurlijk ook door de dagdagelijkse praktijken die er in de zorgverstrekking op het terrein gebeuren en in de interacties met de patiënt. En dit jaar staat er wel een zeer bijzonder subthema centraal bij de World Patient Safety Day. Dat is eigenlijk de veiligheid van die zorgverstrekkers. En laat ons wel wezen dat dat natuurlijk iets is wat ons op dit moment en de voorbije maanden zeer veel heeft bezig gehouden. Dus het hele thema van World Patient Safety Day, de patiëntveiligheid en natuurlijk ook dan de AMR is eigenlijk meer dan ooit relevant. Ik denk dat, zoals Martin Delonois ook zal toelichten, er een aantal zaken in het plan AMR zitten die we met de verschillende overheden en ook met het terrein hebben uitgewerkt, die ten zeerste ook relevant zijn in het kader van de strijd die wij momenteel tegen corona voeren. Als het vandaag gaat over een versterkte aandacht voor aspecten zoals handhygiëne, hygiëne tout court, als we ook meer aandacht hebben voor de belangrijke rol die infectiologen spelen en de belangrijke bijdrage die zij kunnen leveren binnen het gezondheidszorgsysteem en binnen het beleid. Ja, dat zijn allemaal zaken die we binnen het AMR-plan hadden voorzien en waar we aan het werken zijn. U weet dat we relatief recent ook de titel van infectioloog hebben gecreëerd. En dat is natuurlijk iets wat nogmaals sterk wordt benadrukt ook in het kader van de strijd tegen corona. Dat dit natuurlijk elementen zijn die in een performant gezondheidszorgsysteem hun plaats hebben. Nu, Martin zal heel veel vertellen over het AMR-plan, dus ik zal dat iets minder doen. Maar misschien toch ook aangeven dat natuurlijk de patiëntveiligheid is voor ons in onze dienst en in onze FOD zeker ook een kwestie van antimicrobiële resistentie en de strijd daartegen. Maar het gaat natuurlijk ook over andere zaken. En wij hebben in het verleden in onze dienst en in de FOD een hele reeks initiatieven ontwikkeld die op een of andere manier willen bijdragen tot die uitdaging van de patiëntveiligheid. Onder meer de meerjarenkaders die ontwikkeld werden met de algemene ziekenhuizen en de psychiatrische ziekenhuizen, die een belangrijke stimulans zijn geweest in het versterken van de capaciteiten en ook het nadenken in de instellingen over patiëntveiligheid en hoe dat ook concreet kan worden gemaakt. Wij hebben ook initiatieven lopen rond klinische farmacie, waar we de voorbije jaren niet enkel maar de context van de ziekenhuizen bekijken, maar ook steeds meer de transmurale zorg en de transmurale keten van klinische farmacie en ook de wijze waarop in feite de actoren uit de eerste lijn en de ziekenhuizen kunnen samenwerken. Een zeer belangrijk domein waar we ook weten dat er heel veel uitdagingen zijn, niet enkel in ons land, maar ook op internationaal vlak. We hebben dan natuurlijk een aantal initiatieven ook ontwikkeld in onze dienst die te maken hebben met pasgeborenen, neonaten. Waar we proberen om het kindvriendelijke onthaal in de ziekenhuizen, de baby-friendly hospitals, maar ook een hele reeks aspecten rond de wijze waarop we zo goed mogelijk pasgeborenen en moeder kunnen met zorg omkaderen. Daar hebben we natuurlijk ook de voorbije jaren heel wat op ingezet. Ook rond medische beeldvorming, wat u weet dat uit een aantal vergelijkende onderzoeken in België een aandachtspunt is. Wij hebben relatief hoge cijfers van mensen die worden blootgesteld aan straling. En dat vereist dus ook wel een aantal beleidsinitiatieven. Ook daar ontwerken wij met de FOD en ook met het RISIF en een aantal andere actoren aan initiatieven om daar de veiligheid voor de patiënt te kunnen verhogen. Ook rond alles wat heeft te maken met transfusiepraktijken, bloedgebruik en ook het rationeel gebruik van bloed. Daar rond hebben wij initiatieven lopen met het BIQUINT-verhaal. We hebben ook de gekende colleges, ze zijn niet allemaal even actief, maar die ook proberen een bijdrage tot dat thema te leveren. En dan hebben we natuurlijk ook het hele verhaal rond AMR, die een steeds groter deel inneemt van de strategie van de medewerkers en de cellen en diensten die daar binnen het DG en binnen de FOD mee bezig zijn. En ik zou toch ten zeerste willen de Belgische Vereniging van Ziekenhuisdirecteurs danken, want al die initiatieven waarover ik het heb gehad, wat daar typisch aan is dat die tot stand komen, zowel wat de strategie als de implementatie betreft, door een zeer, zeer nauwe samenwerking tussen enerzijds het beleid, anderzijds het werkterrein, maar zeker ook een aantal academische actoren en stakeholders. En de Belgische Vereniging heeft ook in de studiedag die wij een aantal maanden geleden hadden georganiseerd rond AMR actief deelgenomen. En ik dank de vereniging daar ook voor. Er zijn verschillende leiders binnen de ziekenhuizen die daar ook het woord hebben genomen. En ik denk dat het zeer belangrijk is om die handen in elkaar te kunnen slaan. Dus ik wens jullie een zeer boeiende dag vandaag. Het zal ongetwijfeld een aantal nieuwe elementen ook opleveren die wij zullen meenemen in het beleid dat we proberen te ontwikkelen. En tot ziens in hopelijk een andere omstandigheid. Dank u wel. Dag.
Okay, I'm still seeing Pedro on the YouTube channel, but now I'm seeing myself. So before introducing the next speaker, I would like to thank Pedro Facon for sharing this moment with us. I know he has a lot to do, but he wanted to pass a message, and it was done. The exercise today is a bit complicated, so if you see our eyes looking and moving, it is because we are on a webinar, but also with people present in the room. So it's a mixed organization, and it's not really easy to adapt. I'm gonna give the word to Anne Ingenbleek. She is the coordinator for Human Health Services at the Federal Public Service of Healthcare. And Anne, welcome, and the word is yours.
Hello, thank you for the invitation. Indeed, I'm the coordinator of the human aspect of the National Action Plan, which is the subject of today. But I would like to take the word to go on what our director, Pedro Facon, has given just now. So we have prepared some slides, and in a way or another, on your canals or on channels or on ours at the Federal Public Service, we will try to provide you with these slides. And the idea is to remind you with the main words of Pedro today, to put the emphasis on this World Patient Safety Day and the thematic of this year, which is health worker safety, that cannot be forgotten. It's an important aspect of the patient safety itself, to remind that we are all part of this challenge. We will provide you with some reminders, some figures. The initiatives that Pedro has mentioned are also here listed on the slides. And I will go a little bit further. So you have heard about all that, Babcock. So we are all part of this challenge, patient safety, quality of care. It's federal institutions, but it's also the partners from the health sector. It's the ministers, the private association, just like yours, and it's also the international level. I would like to mention also some new initiatives with regard to patient safety that are very much important for you as hospital directors. So I hope this is really a concrete aspect of patient safety in your hospitals. you have the ongoing multi-year plan on quality of care and patient safety for psychiatric hospital especially. This approach has been transformed into a pay-for-performance program in the general hospitals. You are all aware of this program, of course. It's a change of mind, a change of mindset to support the financing of quality in the care. So that's the main aspect of pay-for-performance. I would like to send a call to hospitals who are interested in participating in the board for the clinical trial college. It's ongoing and it's open until the 3rd of October. And in all these aspects, patient safety, we have at the Federal Public Service Health identified challenges and key factors, and we have to work on these challenges using the key factors to be able to improve the quality of our care and to improve the patient safety. The challenges we have seen are the availability of good quality data and data that arrive also on proper time, when we can analyze them, elaborate indicators that will measure, evaluate, and help to improve our practices in our hospitals. It's also a matter of training and awareness, not only once you are trained, but really at the basic steps of your curriculum. We talk about patient safety since a long time, but it's not yet completely embedded into the mind of all our health workers. The transparency to make the care visible for the citizens. The complexity of the Belgian system does not make it easy, but we are going through, and we have learned also during this crisis to go on with that. And the objective is really to integrate the care, that the patient is at the center of our focus. And for these challenges, we have levers, we have aspects that can support an improvement. It's clearly the commitment, the engagement of the manager, of the hospital managers, but of all the health workers also. We have seen it so clearly during this COVID crisis. We are going to rely also on the priorities that the authorities will determine and the means that they will give for these priorities. And then we would like to emphasize the collaboration among hospitals, among themselves, and the collaboration between hospitals and the primary care, especially the elderly care that is really needed. And then to support the patient safety and the quality of care, we are proposing those 4 strategic axes, which are the data-driven care. It means data available to monitor what we are doing at micro level. It means in my service, in my hospital, but also at a higher level, meso, on the regional aspects, and at macro level at the national level. Another axis is the development of a culture on patient safety. It means not only specific projects, one beside the other, but really to think about it at all time. And there are 2 axes oriented towards the health workers on one side and toward the partner itself on the other side, where they are involved. They have to have their word, they have to have their commitment, their engagement to improve patient safety. And I will end here, proposing you to find all this information and also to find the contacts that can be interesting for your hospitals on the projects, but also generally on what the Directorate General Healthcare is doing on the e-zine, the e-magazine online, Be Care. You can find all the information. And I will take the word again later in the day, more specifically on the National Action Plan, the human aspect of the National Action Plan. Thank you.
Thank you, Anne. That was a clear and strong message towards quality and the culture in quality in our hospitals. That reminds us also that our major, our core business is improving health and not always speaking about the financing part of it. So in the meanwhile, Martine Delannoy is ready. Martine is the leading of the One World, One Health project, which is a project from the World Health Organization, and she is leading it in Belgium, and in particular with she is the coordinator for the AMR program, which is the antimicrobial resistance program at the Federal Public Service Health. And the word is yours, Anne. Let's hear what you are going to tell us.
Thank you very much. And thank you for the organization of this day on this very important topic. I will do my presentation in French, as it was told me.
No problem.
So maybe, I don't know if the slides are showing. Yes. Okay. So I am working at the Federal Public Service, Public Health, Food Chain Safety and Environment, in the unit of the president of this ministry, which is who is Tom Owers. And I will speak today for all those administrations that you see there up, because it's a national action plan, and so we develop it with a lot of different partners. So now I speak in French. Donc, pourquoi travailler sur la résistance aux antimicrobiens? Eh bien, vous le savez même mieux que moi, hein, vous tous, directeurs d'hôpitaux, mais évidemment, la résistance aux antimicrobiens, ce sont des vies. Et au niveau mondial, c'est estimé à 700 000 personnes qui meurent chaque année de la résistance aux antimicrobiens. Et certaines études, projections prévoient même que 10 millions de personnes pourront mourir d'ici à 2050, c'est-à-dire plus que les morts dues au cancer, si évidemment aucune mesure n'est prise. En Europe, ce sont 33 000 personnes. Et donc, si on regarde, ça fait 90 personnes par jour qui décèdent à cause de ces résistances à ces médicaments indispensables. Et au niveau belge, les estimations, donc, qui sont des estimations ici de l'OCDE, montrent que 530 personnes, donc au moins 530 personnes meurent chaque année en Belgique, et que ça pourrait aller jusqu'à 22 500 personnes par an, à nouveau, si cette résistance n'est pas contenue. Mais évidemment, la résistance aux antimicrobiens, ce sont également des conséquences économiques. Donc chaque année, au niveau européen, c'est plus de 1 billion d'euros en coûts uniquement pour les systèmes de santé. Et au niveau belge, c'est estimé à 24 millions d'euros annuellement, avec à nouveau des chiffres en 2050 qui pourraient atteindre 785 millions d'euros. Donc ce sont vraiment des coûts importants. Et ici, on ne parle que de ces coûts pour les systèmes de santé. Donc à côté de ça, il y a encore les coûts pour le secteur agricole, par exemple, ou le secteur de l'élevage. Il y a donc ces coûts économiques, ces jours d'hospitalisation supplémentaires pour les personnes qui ont ces bactéries résistantes, donc qui sont difficiles à soigner. Beaucoup de pertes en qualité de vie également, on en parlait au départ, donc chaque année des DALI qui sont perdus. Mais quand même, une bonne nouvelle dans tout ça, c'est qu'il y a des mesures, évidemment, pour lutter contre la résistance aux antimicrobiens, et que ces mesures, en tout cas certaines de ces mesures, sont vraiment cost-effectives, comme on dit. Donc par exemple, l'OCDE montre que les mesures pour l'hygiène des mains, eh bien, si vous investissez près de $2, si vous investissez $1 en hygiène des mains, vous allez en récupérer $2 en frais évités. Si vous investissez $1,35 dans les programmes de stewardship, Non, si vous investissez $1, vous allez en récupérer $1,35. Donc je crois que ce sont des éléments à bien garder en tête dans la lutte contre la résistance aux antimicrobiens. Donc à côté de tous les effets bénéfiques évidemment pour la santé et pour le travail, ce sont aussi des bénéfices économiques que les hôpitaux peuvent retrouver. Alors évidemment, la résistance est liée à la consommation, ça a été prouvé. Et donc, quelle est la situation en Belgique? Donc, où se situe la Belgique par rapport à nos partenaires européens? Donc ici, vous voyez des schémas de la consommation donc, totale d'antimicrobiens donc, dans la communauté, donc, c'est-à-dire les médecins généralistes, les maisons de repos notamment. Et on voit, entouré en rouge, la Belgique qui est plutôt dans la queue du peloton. Donc, nous sommes, nous consommons en tout cas beaucoup plus d'antimicrobiens par habitant que la plupart des pays européens. Si nous regardons au niveau du secteur hospitalier, donc là, les chiffres sont meilleurs. Donc, nous sommes au-dessus de la moyenne européenne, en tout cas dans le bon sens. Donc, nous consommons un peu moins que la moyenne européenne. Maintenant, ces chiffres montrent de grandes différences entre les hôpitaux. Ça, c'est un fait. Et d'autre part, il faut savoir que la plupart des résistances, et en tout cas des conséquences négatives des résistances, s'attrapent dans les hôpitaux selon les études. Alors, ici, l'évolution donc, de la consommation des antimicrobiens au niveau du secteur humain, ici dans le secteur ambulatoire. Donc, on voit depuis 1997 jusqu'à 2017, on voit une tendance à la baisse qui est progressive, légère, mais qui est présente. Donc, ça, des mesures sont prises et c'est très bien. Au niveau des hôpitaux, également, il y a eu, on voit au début des années 2000, une forte diminution de la consommation des antimicrobiens dans les hôpitaux belges. Ça correspond également à la création de Babcock, le Belgian Antibiotic Committee. Mais on voit une légère diminution, pour ne pas dire une stagnation les dernières années en termes d'évolution. Bon, ce sont les chiffres bruts pour tous les hôpitaux. Hein. Il y a évidemment des différences par hôpital, mais voilà les grandes tendances en tout cas. Alors si on regarde au niveau vétérinaire, parce que je suis ici pour vous parler de One Health, où se situe la Belgique en termes de consommation d'antimicrobiens dans le secteur vétérinaire, eh bien, si on voit dans ce schéma, la Belgique est plus ou moins à le huitième plus gros consommateur au niveau européen. Alors il y a beaucoup de pays qui sont pas très loin de la Belgique, mais à nouveau, la Belgique a fait beaucoup d'efforts dans ce secteur depuis plusieurs années, mais on voit par rapport à d'autres pays européens ou des pays voisins qui auraient moyen d'améliorer les choses, comme pour les autres secteurs de l'ambulatoire ou du secteur hospitalier. Et donc ça c'est l'évolution au niveau animal, une diminution de la consommation depuis 2011 notamment, mais je laisserai le professeur De Wulf vous donner tous ces détails plus tard dans la journée. Alors pourquoi travailler au niveau One Health? Donc pourquoi un plan One Health? Vous le disiez, vous parliez de l'OMS. Effectivement, donc au niveau international, une grande prise de conscience et une grande pression pour demander aux États de travailler de façon coordonnée sur cette thématique. Et donc nous avons un plan d'action national de l'OMS, nous avons également de l'OIE, donc qui est l'Organisation internationale pour les animaux, nous avons de la FAO pour l'agriculture, du Codex, tout ce qui est alimentaire. Et au niveau européen, nous avons également un plan d'action au niveau européen et des conclusions du Conseil en 2016 et en 2019. Donc on voit au niveau politique, c'est un sujet qui, heureusement, est porté au niveau politique. Alors, pour notre SPF, c'était important de travailler, de développer un plan One Health, parce que le SPF veut apporter une approche intégrée de la santé. Et intégrer de la santé, ça veut dire qu'on veut intégrer les interconnexions et les interdépendances entre les secteurs, donc la santé humaine, la santé animale, la santé des plantes et la santé de l'environnement, puisque tout est interconnecté. On veut bien analyser l'impact et l'influence de tous les secteurs, donc sociaux, économiques, l'éducation, la mobilité. Et on veut également prendre en compte l'influence des méga-tendances, donc les inégalités sociales, par exemple, la globalisation du monde, évidemment en référence avec les SDG, les objectifs de développement durable. Donc voilà, on veut une approche transversale et globale, et donc j'en arrive enfin à ce plan d'action national One Health pour lutter contre l'AMR. Donc voilà, ce qu'on a voulu, c'est une approche One Health avec un seul plan qui regroupe toutes les actions dans les différents secteurs, parce qu'évidemment ces secteurs sont liés. Donc on voit les petits animaux au milieu de mon schéma. Ces animaux reçoivent des antimicrobiens et peuvent porter des bactéries résistantes aux antimicrobiens. L'éleveur, le vétérinaire est en contact avec ces animaux. Idem les animaux de compagnie que chacun a chez soi, ils peuvent également être porteurs de bactéries résistantes. On les caresse, voilà, il y a ce partage qui se fait dans les deux sens d'ailleurs. Également évidemment dans l'environnement, tout ce que nous consommons, les déchets de résidus se retrouvent dans l'environnement, dans nos eaux de baignade. Il faut savoir par exemple qu'une étude aux Pays-Bas a montré que 89% des stations d'épuration retrouvent des bactéries CPE dans leurs stations, donc avant l'épuration des eaux. Donc voilà, dans l'environnement, ces bactéries résistantes sont présentes. Et donc on veut également un plan qui touche aussi, donc pas uniquement les antibiotiques, même si c'est la majeure partie de nos actions, mais également les antimicrobiens au sens large, donc aussi tout ce qui est antifongique par exemple. Et on veut évidemment une vision nationale et donc intégrer un maximum d'acteurs, et donc évidemment donc vous êtes des acteurs principaux. Donc ce plan est coordonné par le SPF avec une collaboration très étroite avec l'Agence des médicaments, l'Agence fédérale pour la sécurité de la chaîne alimentaire, l'INAMI, Cienzano. Évidemment également des contacts et des discussions avec les régions et les communautés au sein de conférences interministérielles, et un travail étroit avec la Babcock, donc la Commission belge pour les antibiotiques, et l'AMCRA, qui est le pendant en santé animale, et qui sera détaillé plus tard. Alors, en vitesse, comment ce plan, ou ce projet de plan en tout cas, a été élaboré? Mais tout d'abord, on s'est basé sur des analyses détaillées de la situation belge. Et nous avons eu pour ça des rapports de visite de l'ECDC au niveau européen, de la Commission européenne, même de l'OMS. Nous nous sommes basés sur un très bon rapport du KCE, donc, que nous avions commandité. Qui est paru en avril 2019, un rapport également sur l'évaluation du protocole d'accord sur les MDRO. Et ensuite, voilà, nous avons toute une série de rencontres et de consultations avec tous les stakeholders pour arriver à un projet. Alors, ce projet, c'est un plan d'action qui se développe en 10 axes stratégiques, dont les 2 principaux sont le stewardship, donc l'utilisation prudente d'antimicrobiens, et ensuite la prévention et le contrôle des infections, donc un thème que nous connaissons tous, d'autant plus avec la crise que nous subissons actuellement. Il y a également des plans de travail sur les systèmes d'information, donc tout ce qui est partage de données, sur les audits et les contrôles, sur la communication et l'éducation à la lutte contre la résistance aux antimicrobiens, sur des objectifs cibles pour essayer de motiver les gens, comment voir que le travail progresse. Eh bien, travaillons avec des targets, des indicateurs que nous allons suivre chaque année. Évidemment, une coordination des projets de recherche pour réussir à avoir des réponses à nos questions. Un contexte économique, donc vérifier comment, au niveau économique, on peut améliorer, par exemple, la disponibilité d'antimicrobiens. Et évidemment la coopération internationale et la gouvernance pour prendre tous ensemble ces décisions. Alors, donc ces 10 objectifs opérationnels, enfin ces 10 objectifs globaux ont été traduits en objectifs opérationnels et en, vous voyez, 234 actions. Donc c'est énorme. Donc ça montre le nombre important d'actions qui peuvent être mises en place et toutes les idées qui sont revenues de toutes ces différentes consultations. Et donc évidemment il y a des actions qui sont spécifiques à un secteur, mais il y a également des actions qui sont plutôt transversales à d'autres secteurs. Voilà, je ne vais pas vous détailler évidemment toutes ces actions, mais je voulais vous montrer en tout cas que le travail a été fait de mettre tout ça par écrit, de digérer tous les rapports existants pour avoir un plan de travail détaillé. Alors, je vais quand même donner quelques exemples d'actions, et peut-être un peu plus dans votre secteur, dont de la santé humaine, et ma collègue Anne Ingenblek pourra compléter. Mais donc, par exemple, les actions pour améliorer l'utilisation prudente des antibiotiques, eh bien, c'est de renforcer les pratiques, les pratiques de prudence, et de donner le bon antibiotique, et uniquement quand c'est nécessaire. Donc avec des guidances qui sont mises à jour régulièrement et qui sont publiées dans des endroits stratégiques. La disponibilité de médicaments, donc faire pour que les médicaments soient sur le marché et dans des doses qui sont acceptables pour ne pas avoir des déchets qui, par après, pourraient se retrouver dans l'environnement. Et on revient dans notre boucle One Health. Le directeur général, M. Pedro Facon, a expliqué le prochain point, qui était la reconnaissance de la spécialité d'infectiologue et de microbiologiste, qui était un point qui nous revenait très fort du terrain. Donc besoin de cette reconnaissance pour que leur rôle dans leur travail soit amélioré, et que, évidemment, donc, leur implication aussi améliorée. Le fonctionnement des groupes de gestion de l'antibiorésistance. Donc ça également très important dans vos hôpitaux. Vous êtes financés, c'est pour la constitution de ces groupes, de ces personnes qui se battent tous les jours et qui donnent des conseils pour lutter contre la résistance aux antimicrobiens. Eh bien, il faut optimiser le fonctionnement et suivre ce fonctionnement. Et également de l'aide dans le secteur des soins de santé ambulatoires pour aider toute la consommation prudente dans ces secteurs. Alors au niveau de l'objectif qui est la prévention des infections et le contrôle des infections, il y a toute la stratégie et un protocole d'accord sur les MDRO, donc les Multi-Drug Resistant Organisms. Et donc ça, on veut continuer à défendre, à aider la mise en place de ce protocole d'accord, en collaboration évidemment avec les communautés et les régions. Également le fonctionnement des IPC, donc des équipes de Infection Prevention and Control dans vos hôpitaux. Donc on considère qu'il faut les renforcer. Ils ont énormément de travail, ils ne sont pas suffisants. Donc on voudrait renforcer ces équipes, renforcer leur nombre. Et également renforcer toutes ces mesures de précaution, donc notamment la campagne hygiène des mains, dans les structures annexes aux hôpitaux, donc on va dire toutes les maisons de repos et maisons de soins, voire améliorer les contacts entre les hôpitaux et ces réseaux pour avoir un transfert de connaissances et s'entraider. Alors concernant les systèmes d'information, eh bien l'accès aux données est très important pour pouvoir évaluer la situation, pour pouvoir voir les progrès qui ont été fournis. Et donc, on veut améliorer ça, avoir les bonnes données. Donc, il ne faut pas avoir des données sur tout, mais avoir des données qui soient pertinentes et qui puissent nous aider à prendre des meilleures mesures dans le futur. Également, améliorer la notification des incidents à MDRO. Et le monitoring de la résistance aux antifongiques qui se développe parfois contre l'aspergillose, notamment tout ce qui est résistance aux azoles. Alors, il y a également un objectif de targets. Donc, on veut développer des objectifs cibles en santé humaine. Vous verrez en santé animale qu'il y a des objectifs très, très clairs qui sont monitorés chaque année, et on pense qu'avoir ce genre d'objectif aussi clair peut aider aussi au niveau de la santé humaine et aider dans la communication surtout qui sera faite et à stimuler la prise de mesures. Enfin, le dernier exemple en santé humaine, c'est des mesures par rapport à l'audit et les contrôles. Donc, c'est d'avoir un système de validation des données, donc des indicateurs qui seront validés de façon externe pour, à nouveau, pour avoir les indicateurs pertinents et avoir un suivi de ceux-ci. Alors, en très court, quelques idées, mesures phares au niveau de la santé animale. Mais c'est également des mesures préventives en santé animale. L'hygiène des mains, ce n'est pas que pour la santé humaine, c'est aussi pour la santé animale, tout ce qui est biosécurité. Également des mesures de coaching qui sont très développés en santé animale, donc le suivi de chaque prescripteur, donc les vétérinaires dans ce cas-ci, et également le suivi des utilisateurs, donc des éleveurs, qui sont, qui ont un monitoring précis et qui reçoivent des bulletins. On peut dire un bulletin comme à l'école, avec une couleur. Vous êtes rouge, vous êtes vert, vous êtes orange. Et c'est pour les permettre de se comparer par rapport à des éleveurs similaires qui sont dans la même situation, avec le même cheptel, pour tirer vers le haut et montrer que c'est possible de travailler avec moins ou d'autres types d'antibiotiques. Alors des conditions très strictes pour certaines classes d'antibiotiques qui sont appelées critiques, notamment critiques parce qu'ils sont utilisés en santé humaine justement. Et une extension du rapportage de l'utilisation pour l'étendre également aux animaux de compagnie. Donc actuellement, tout ce qui est consommation d'antibiotiques est très bien suivi sur certaines espèces d'animaux de rente, donc les animaux que l'on consomme, mais on veut travailler pour également faire ça pour les animaux de compagnie, qui peuvent également être une source de développement de résistance. Et donc ça intègre également tous les objectifs de l'AMCRA. Au niveau de mesures qui sont un peu transversales au secteur humain et au secteur animal, on a le développement d'outils de diagnostic qui soient plus rapides, qui permettent plus vite de guider le prescripteur dans le type d'antibiotique à prescrire. Et donc, ça pourrait par exemple se faire via une étude du KCE. Il y a également des mesures qui sont prises par l'Agence des médicaments pour stimuler le maintien sur le marché de certains types d'antibiotiques, souvent des anciens antibiotiques qui, à cause de la taille du marché belge ou à cause d'autres éléments économiques, ont tendance à disparaître de notre marché ou à être peu disponibles à certaines périodes. Donc tout un travail de l'Agence des médicaments par rapport à ces antimicrobiens. Et également par rapport à la vente illégale en ligne, donc ce qu'on appelle l'e-commerce. Et ensuite tout un pan de travail sur des modèles économiques pour justement stimuler le développement de nouveaux antimicrobiens. Par exemple ici, on parle aussi de la thérapie avec les phages. Donc voilà, voir comment ce nouveau type de produit peut faire sa place sur le marché belge, puisqu'un intérêt est présent. Alors au niveau de l'environnement, parce qu'on est bien One Health, et donc on regarde aussi, on a aussi des mesures pour le côté environnemental. Eh bien, un premier pan d'action est l'analyse du profil environnemental des antimicrobiens. Parce que, bon, évidemment, quand on prescrit, la première remarque, c'est le bon antibiotique pour lutter contre la bonne bactérie, par exemple. Mais à plusieurs antibiotiques égaux en efficacité, on pourrait se dire, s'il y en a un qui fait des dégâts au niveau environnemental, qui reste très persistant dans les eaux, eh bien, celui-là, peut-être, devrait être moins choisi qu'un autre. Un monitoring aussi de la résistance donc, aux azoles dans l'environnement. Donc, les azoles sont utilisés également en agriculture en tant que fongicides, et donc voir si cette utilisation peut avoir un effet sur la résistance aux azoles que l'on retrouve chez les personnes et dans les hôpitaux. Enfin, tout un travail de monitoring environnemental, puisqu'on a très peu de données à ce jour sur quels sont les résidus d'antibiotiques dans les eaux. Donc c'est une compétence régionale. Les régions font des études ponctuelles, donc on a des données, mais pas quelque chose de continu. Et donc on voudrait améliorer ça et avoir un suivi plus continu de cette présence dans l'environnement. Et on a également commencé des discussions avec les stations d'épuration d'eau qui peuvent choisir certaines techniques qui parfois permettent d'éliminer plus les antimicrobiens dans les eaux que d'autres techniques. Au niveau d'action One Health, vraiment, donc la première action est un rapport annuel One Health sur l'utilisation et la résistance aux antibiotiques en Belgique. Donc actuellement, ces données existent, mais sont réparpillées dans plusieurs rapports. On voudrait centraliser ça dans un rapport et surtout voir s'il y a des liens entre, par exemple, la consommation dans le monde animal et une résistance dans le monde humain, ou entre l'environnement et le monde humain. Donc l'objectif est de vraiment faire une analyse croisée de ces résistances et consommations. Également une analyse génétique des résistances, donc pour aider à comprendre justement les transferts de résistance. Bon, évidemment, on sait que le MRSA, voilà, certains en Belgique, on estime à 10% d'MRSA qui viennent des élevages. Enfin, en tout cas, c'est un chiffre de l'ICDC. Mais donc, quand on fait des analyses génétiques des micro-organismes, on peut avoir plus d'informations et comprendre quelle est l'origine de cette résistance. Est-ce que c'est une transmission au sein de l'hôpital ou est-ce que ça vient de l'extérieur? Également des actions en termes de communication, One Health, donc quand on communique auprès des gens, quand on leur dit les antibiotiques, c'est pas automatique, pas d'office pour une bronchite, certainement pas pour une grippe, mais on peut dire aussi et pas pour votre chat ou votre chien, c'est pas toujours nécessaire. Quand c'est nécessaire, évidemment, il faut les prendre, mais soyons attentifs à ça également. Tout un pan par rapport à l'éducation, donc tant l'éducation pendant les cours universitaires, mais également tout ce qui est formation continue. On voudrait stimuler le suivi de ces formations pour la résistance aux antimicrobiens via par exemple plus de points qui pourraient être fournis pour ce genre de formation. Et voilà, évidemment, tout ce qui est recherche également pour identifier ensemble des projets de recherche. Voilà un aperçu de quelques-unes des actions phares. Donc, toutes ces actions devraient être reprises donc, dans un document qui est plutôt stratégique et qui expose cette vision et ses goals, ses objectifs stratégiques. Donc voilà, ce document est prêt, mais il attend une validation. Nous avons également un site internet où toutes les informations sont disponibles. Et voilà, j'en arrive à ma dernière slide, mais où en sommes-nous actuellement? Donc, toutes les mesures que je vous ai expliquées, la plupart de ces mesures sont déjà en place, commencent. Tous les acteurs qui nous ont aidés à développer ce plan, évidemment, travaillent, n'ont pas attendu une validation politique. Mais quand même, on aimerait quand même bien avoir une validation politique et avoir surtout également des budgets supplémentaires pour les actions clés que nous avons identifiées. Donc on avait en mars un projet de plan d'action, hein, donc le NAP, National Action Plan, donc qui a déjà été en tout cas validé au niveau fédéral belge. Mais ensuite est arrivé le Covid qui nous a volé, hélas, la vedette. Et donc, les prochaines étapes, c'est une validation politique au niveau avec les ministres fédéraux, donc, je suppose du nouveau gouvernement, puisqu'on l'espère, il arrivera vite. Et ensuite une validation aussi politique dans les conférences interministérielles, parce que l'on veut vraiment que ce plan soit porté par les communautés et les régions également. Ce sont des objectifs communs, il y a des actions pour les différents niveaux de pouvoir. Donc voilà, les groupes de travail sont déjà en place dans ces différentes conférences interministérielles, les personnes ont déjà participé, mais maintenant on voudrait vraiment une validation politique. Et donc en espérant que le NAP sera validé en fin de l'année pour une implémentation sur les 4 années suivantes. Mais donc voilà, pour rappel, les actions sont en cours. Je parle des actions exposées dans le NAP, mais elles comprennent également toutes les actions sur le terrain, les actions de la Babcock et donc toutes les actions que vous prenez dans les hôpitaux, qui sont prises chez les médecins généralistes. Voilà, c'est un plan qui se veut vraiment intégratif et pour ça, je vous remercie encore pour la journée d'aujourd'hui et pour le travail que nous pouvons faire ensemble.
Merci, Martine. Thank you, Martine Delannoy. This was a real overview of all actions taken in Belgium. I learned a lot of all this. I would like to state that we organized this day before the COVID epidemic. And of course, what you heard seems like theoretical. And now that we had this coronavirus crisis, we know that it's not theoretical anymore. So hand hygiene and preventive measures can really help. We also heard that it is difficult to put all these plans in action in our country with different levels of different authorities and different levels of responsibilities. I would like to invite Professor Jean-Louis Vincent, who will be the next speaker, because Professor Doucet-Populaire, Florence, couldn't make it from Paris, not because of the COVID crisis, but because she had some educational things to take care of. Last time I met Professor Vincent, welcome. It was in Thailand, and we spoke about the same subject. It was about antimicrobial resistance. So Professor Vincent is going to tell us, I suppose, that these bacteria kills people, kills humans. And Professor Vincent is past chief of service of intensive care unit in Erasmus University Hospital, and still taking care of the European Society of Intensive Care Medicine, and also, of course, I suppose, past president of the European Society of Intensive Care. And he has a huge experience with what does these bacteria do in our daily life. And before giving him the word, I would like to share with you the one-word concept. It's one health, one word, one world. And of course, we see this now with the outbreak of the coronavirus. And we could have an outbreak maybe someday of some really bad bacteria, correct? Please.
Thank you very much. It's a pleasure to be here and to bring indeed an intensive care medicine aspect to it. And actually, I will show you that it's not necessarily the bacteria that kill the host. It's largely the host response when it is disorganized, inappropriate, and that's what we call sepsis. It's not a disease. Sepsis can be associated with many diseases like pneumonia, peritonitis, etc. But it's a syndrome. And we often use the word sepsis in the clinic, as we know. And that really refers to a bad infection. What do you mean, a bad infection? The doctor will immediately add words like hypotension, or disorientation, what we call delirium, oliguria, etc. So there is always some form of organ dysfunction when we speak about sepsis. So as I reviewed here with a couple of colleagues, the presence of bacteria without host response, that is colonization. And we are all colonized, our gut being the best example, or our mouth. But when there is some host response, like fever, the associated tachycardia, the altered white blood cell count, we speak about an infection. We speak about sepsis when the situation becomes more severe, as I just mentioned, when there is organ dysfunction attributed to it. And the most severe form of sepsis is what we call septic shock. Shock meaning that the tissues are no longer well perfused. There is typically hypotension. There is an increase in blood lactate levels. The mortality rates now reach about 50%. Every other patient will die. So when we speak about all this, we need to separate definition and criteria. Pneumonia, that's a lung parenchymal infection. And there are several criteria. A myocardial infarction, to diagnose it today, we want to have the troponin level, but myocardial infarction existed before troponin levels were available, right? So when we speak about sepsis, the definition is a dysregulated host response. The word dysregulated is an important one. It's not just too pro-inflammatory, because we know today it is both pro-inflammatory and anti-inflammatory. But this dysregulated host response is responsible for organ dysfunction. Now, very briefly, it's important to go back to a little bit of history. In 1991, the Americans proposed that we defined in terms of criteria that we look for SIRS with infection. And SIRS was just a little bit of fever and or a little bit of tachycardia and or a little bit of tachypnea and or a little bit of an alteration in white blood cell count. Whenever there are two of these abnormalities, okay, infection plus this equals sepsis. That was very bad because these are signs of infection. So it brought confusion. The number of sepsis cases around the globe increased substantially because people started to call infection sepsis. So already 7 years ago, my colleagues and I wrote this piece saying, you know, we need to change it. It's no longer possible to refer to SIRS. We should abandon it. And so we had a consensus conference a few years ago where we decided that SIRS is dead. We should no longer speak about it. And so now, again, as I mentioned, sepsis is organ dysfunction associated with an infection. As we wrote here, this is the definition. The criteria, okay, you need criteria for a scientific publication. How did you select your patients? Since there is acute organ dysfunction, we said, okay, there should be an increase in SOFA score by at least 2 points. Voilà, just a way to characterize an acute degradation of the organ function. And for the public, we said it's primarily an inappropriate response to the invading organism. And for children, it's the same. So if you speak to pediatricians, it's the same. Now, incidentally, as you can see just below there, the word septicemia is outdated. In the public, people still speak about septicemia, but it doesn't make sense because septicemia indicates that there is something in the blood. And we know that blood cultures are not always positive in severe infections. We need to look for it. We need to take blood for blood cultures, of course. And we hope actually to find a microorganism to reorient our antibiotic strategy. But in perhaps about 50% of the cases, the blood cultures remain negative. So sepsis and septic shock in particular is treated by 3 components. The hemodynamic management, we will need to give fluid, sometimes vasoactivations, especially when there is shock. We need to raise blood pressure with vasopressors. Sometimes the modulation of the host response with corticosteroids, for instance. We will not speak about all this. We will focus, of course, on infection management, antibiotics, and source control when needed. If there is a peritonitis, we may need a surgeon to open the abdomen. Otherwise, the patient will not get better regardless of the value of our antibiotics. We need to look at the evolution and management. We briefly spoke about preventive measures, hygiene, clean water, vaccines. Of course, this is not for us in the intensive care unit. But we need to focus on early recognition of sepsis. And this could occur already at home, in the emergency room, on the hospital ward, and the patient should be brought in the ICU, but sometimes sepsis develops in the ICU. So we go back to the 3 elements of the management, keeping in mind, and some people sometimes forget to mention that there may be some ethical limitations. We have known it with COVID-19. Some people were not brought to the hospital or not brought to the ICU. They were not treated by mechanical ventilation. But this is true for sepsis in general. A patient with terminal cancer and sepsis may not really require a full support. Early recognition, as I indicated, sometimes it is the infection first, and then we look for the signs of organ dysfunction. But sometimes it's the other way around. In the hospital, we need to think at sepsis whenever there is a new organ dysfunction which is not well explained. So this is a fundamental chart scheme for the hospitals, for everybody working in the hospital, the pediatrician, OBGYN, ophthalmologist, cardiologist, name it. They should consider that any unexplained organ dysfunction, the patient is getting confused, or there is oliguria, or there is a fall in platelet count, that can potentially be sepsis. So we need to largely rely on nurses who are more often at the bedside than doctors. And clearly, sepsis does not occur only in the hospital, it can occur anywhere. And as it was alluded to, the World Health Organization stated less than 1 month ago that healthcare-associated infections are often resistant to antibiotics and can rapidly lead to deteriorating clinical conditions. Antimicrobial resistance is a major factor determining clinical unresponsiveness to treatment and rapid evolution to sepsis and septic shock. Sepsis patients with resistant pathogens have been found to have a higher risk of hospital mortality. Around the globe, this is a very interesting paper, published already 3 years ago now, estimating that in the globe, there are perhaps around 50 million cases of sepsis, and most of them are children. The most common source, actually, is the GI tract, is diarrhea before the lungs. And you can see that the global death rate is about 20%. And when you look at the world map, it's interesting. Both the incidence and the incidence of death, the incidence of sepsis and the incidence of death, show about the same colors. It means that in Africa, in South India, in South America, the problem is even much worse than in our regions in the Northern Hemisphere. Now, all these evaluations globally are limited because the sepsis criteria are not very well defined. And again, a patient may die from his terminal cancer or her terminal cancer with sepsis, but the cause of death is actually the cancer. We had the same thing with COVID-19. A number of patients were considered to die from COVID-19 when actually they had a terminal disease. So, speaking about infection control and antibiotics, if we think that antibiotics work, and I suppose we are all convinced that antibiotics work, we need to give them early when indicated. I'm saying we hope that antibiotics work because there are some people who sometimes say, you know, we have no prospective randomized control trials showing that antibiotics work. And the same people may defend homeopathy, maybe, you know, saying, you know, there is no prospective randomized control trial. Okay, but there is none on antibiotics either. But we have, of course, strong evidence that antibiotic therapy can be very effective. So in critically ill patients, we should start early. And of course, we should give the adequate antibiotics. We should not give penicillin in complex infections. It will not work. So speed and adequacy of antibiotic therapy are particularly important in very severe cases. So these are very important elements when we speak about resistance to antibiotics, because sometimes now we give antibiotics too early, too rapidly, especially in the US. This is a paper that made a lot of noise. The figure is very nice, but nobody believes in that. Can you really believe that for 1 hour delay in antibiotic therapy, the mortality rates go up? Have you seen in medicine a relationship like that for anything? No, that was done by medical students under the supervision of the author, and things are not that straightforward. We could analyze a number of papers and show that indeed in severe cases, like in septic shock, giving the antibiotics early can result in better outcomes. And it's true that in emergency rooms in particular, sometimes time is wasted. Have you given the antibiotics? Oh, no, I had no. I had no time to, well, you should do it. Yeah, but I have to go and take the antibiotic. I have to prepare the antibiotic. I'm very busy. So we need to tell people that they should not waste time. If you give antibiotics more than 1 or 2 hours after arrival for a severe infection, it may be associated with higher mortality rates. And if you look at big series, like here, in serious gram-negative bacterial infections, the longer you wait, the higher the mortality rate globally. But we need also to take into consideration that sometimes antibiotics were given relatively late when the situation was not straightforward. Today, we insist on the fact that patients may not have fever, so we may miss the diagnosis of an infection. Or it's a patient with cardiac problems and some lung infiltrates on the chest x-ray, etc. So it's not easy to really interpret all this literature. But in the US, following a study like this, it has been mandatory to give antibiotics within 3 hours following admission in the emergency room. And that's the point. People sometimes give too many antibiotics. They go ahead and give antibiotics for patients who may come with a pulmonary edema due to cardiac failure or due to something else. Or even if it's a gastroenteritis, maybe antibiotics were not needed. So that's a very important element, and I will actually skip a little bit of this to go quicker to the bottom line to indicate that the every hour delay is not really seen in the recent literature. This is a paper from a few months ago. This is a meta-analysis for this year. We should not rush in patients who are not too sick. Of course, if it's a meningococcemia, we need to give antibiotics right away. If it's septic shock with hypotension, need for vasopressors, yes, quickly. But if it's not such a severe case, we may have time to think about it, perhaps spare some antibiotics. So if it's urgent, we need to give it very quickly. If it's less severe, we may have a little bit of time. And about the choice, it's about the same problematic. In New York, in the US now, they bombard people with broad-spectrum antibiotics in the emergency room because they are afraid to be in face of a resistant microorganism. And that's a big issue. Let me quickly go over data from intensive care units around the globe. I am the past president of the World Federation, and we did this ICON study looking at the type of microorganisms we could find in infected patients in more than 10,000 persons in 700 ICUs in 84 countries. And we can see that in the ICU, there are many infected patients. The majority of patients are infected in most part of the world. And especially those patients who have been in the ICU for several days. Then they develop microorganisms, and of course, they are not necessarily the same as at the very beginning of the stay. There is more Klebsiella, more Candida, more Pseudomonas, more Acinetobacter than in the early stages of their stay in the ICU. But very interestingly, there has been a shift from gram-positive to gram-negatives as predominant microorganisms in recent years. So now, everywhere in the world, except perhaps in North America. In North America, it's also more prevalent, but the differences are not as big as in Europe and especially in Asia, where the problem of gram-negative organisms is absolutely spectacular. Staphylococcus aureus is less of a problem than some years ago. As I said, Klebsiella is now at the top of the list. E. coli, of course, and Pseudomonas, of course. Acinetobacter is rising as a predominant microorganism. And we should not forget about fungi, but this is not really our focus today. So when we look at a 10-year period between two of our studies of this kind, we can see that Pseudomonas maybe is a little less prevalent, but Klebsiella is going up and Acinetobacter is going up. And Staph aureus is maybe going down somewhat in many parts of the globe. So, of course, patients who have been in the hospital for a while are more likely to have resistant organisms, and then the problems arise. And this is an additional reason to try to limit the use of broad-spectrum antibiotics too wisely in patients who are in the hospital and in the ICU in particular. The aspects of resistance will be covered later. Now, some years ago, we were very interested in these studies showing that giving an initial inappropriate antibiotic therapy is associated with worse outcomes. But if you think about it, it's expected. If you think that antibiotics work, of course we need to give the right antibiotic to start with. Again, if you give penicillin to a very complex gram-negative infection, it won't work. It will be like water. So this was not too surprising. And again, the population may be different too. Patients who receive the inadequate antibiotic may be the ones having unusual microorganism or particularly resistant microorganism. So this patient population may be different from the more standard population. So when we speak about broad spectrum, we could add different antibiotics and even a antifungal therapy, but we try to urge our colleagues not to be too broad and too aggressive with the initial antibiotic therapy. Of course, we need better tools for microbial identification, and it's a whole different story. How could we identify the microorganism more rapidly than with the current techniques? I will not address it here, but in the future, it's clear that we will be able to orient the antibiotic therapy a bit more rapidly, either from the very beginning or after the first dose or the second dose of antibiotics. So it will help us to decrease the spectrum or avoid even starting antibiotics. So the current scheme, to summarize what we have said so far, is that if there is a severe infection, if the patient is in shock, it's urgent. We need to give broad-spectrum antibiotics, of course. But if the patient is not in shock, we may have time to reevaluate and either withhold antibiotics or give what I would call a reasonable antibiotic therapy. And we should always reevaluate our antibiotic strategies. So it's both timing and choice. Taper vite et taper fort, it was said in French by Paul Ehrlich, who got the Nobel Prize a little more than 100 years ago. And indeed, studies show that both timing and spectrum count, but if the situation is not too severe, maybe we have the time to think. This is an old study, but I love it, because it shows that when you give antibiotics very early because you are concerned about medical legal implications, you are concerned about your boss that will be unhappy, you may give antibiotics earlier, but you may actually end up with treating patients who may not have the pneumonia that you suspected. So you give antibiotics to patients who do not need the antibiotics. This is a very nice study. It was also published a while ago, but it showed that for ICU-acquired infections, if you give an aggressive antibiotic therapy without thinking much, actually antibiotic therapy will be less commonly appropriate, and there may be more fatalities than if you take a little bit of time to discuss with the infectious disease specialist, as we do in Brussels and as we recommend people to do everywhere. We need to try to think whenever we can think. And of course, consider de-escalation whenever we receive the information from the bacteriology laboratory to limit the antibiotic pressure. In our department, if you look at all nosocomial infections, we can de-escalate in 43% of the cases. It's not the majority of cases. Of course, sometimes we need to escalate. We need to add the additional antibiotic because you realize that your microorganism is resistant to the antibiotics you have started. You may need to add colistin, or you may need to add another antibiotic. So, and we should not forget that antibiotic therapy should be given for a limited period of time. It could be guided with what we call sepsis markers, like C-reactive protein or procalcitonin, PCT. And by doing so, this is just one of many studies, we could perhaps limit the duration of antibiotic therapy in patients who improve rapidly. And that's a good way to limit the resistance to antibiotics, of course. It's always the same thing. We need to limit the spectrum and limit the duration of our antibiotic therapy. And in this recent study, it's even suggested that the use of procalcitonin for this may improve survival of patients. So it's not a minor thing to do. And we believe in Belgium in general, perhaps in Brussels in particular, that C-reactive protein levels, CRP levels, may be almost as good as PCT levels. So to finish up, it's a challenge. Because if the patient is critically ill with sepsis, we need to apply an early and effective antibiotic therapy, no doubt about this. But at the same time, we would like to limit our antibiotic therapy to try to limit the risk of resistance and, of course, the toxicity and costs. And at our scientific meetings, critical care meetings, emergency meetings, you often have two rooms. One room on emergency medicine where people say, give broad-spectrum antibiotics early to all patients who arrive in the emergency room and may be septic. And you have in the next room a session where we speak about multi-resistant organisms and where we say, no, try to use antibiotics sparingly, not too liberally. And, and these are two sessions at the same meeting with the same people who could attend the session. So this is the equation. Sepsis, it needs a rapid action. We need to cover for all microorganisms, but therefore we would like to use broad-spectrum antibiotics. But therefore there may be an increase in microbial resistance. And therefore we may actually use more broad-spectrum antibiotics early on. And that's a big issue, especially if there are medical legal issues that are coming up in North America, and they may come up in Europe as well, because people start to be interested in what we do, of course. It's their right. And they may say, wait a minute, you do not give enough broad-spectrum antibiotics here, and that could be a problem. So start early, very early in severe cases, but discuss whenever time allows it. Use a probabilistic antibiotic therapy, as we will hear in just a moment, I suppose. We should try to avoid broad-spectrum antibiotics in outpatients without particular risk. We need to have a probabilist approach, indeed, and we should not forget source control. I'll stop here. Thank you.
Thank you, Jean-Louis. This was a rapid course in intensive care and sepsis management. So I really hear you spoke about the supportive services like the intensive care and its importance. I cannot avoid comparing to the COVID crisis, So all you said, we have lived it. People and hospital managers experienced the situation, how many intensive care nurses we have, how many ventilators we have, what's the need of the team in the intensive care. So at the end of the comparison, the coronavirus doesn't have a treatment. So we have antibiotics, but if I understand, we have to use them in the right way. And as you said, we have to call the infectious disease specialist. So let's hear her. Yep. And I would like to introduce Professor Maya Hites, who works at the Erasmus University Hospital as an infectious disease specialist, and who tell us what we need to know about bacteria in clinic and how bacteria becomes resistant to all the drugs we have, and at the end maybe an epidemic like the COVID-1 could happen. Correct?
Yes.
Please.
Thank you very much for the invitation, and I'm very pleased to be here to be able to talk about a subject that I think is extremely important, and so I think we can begin. And so I'm going to begin with an introduction. We're going to talk a little bit about why is there antibiotic resistance. We'll talk about a little bit of the situation, the epidemiological situation in Belgium. And then I thought that the best way to present the clinical situation in Belgium is to actually present several clinical cases that allows you to see the complexity of the patients that we have to deal with when they present infections due to very multi-drug resistant bacteria. And I will finish with some conclusions. And so, as we all know, the spread of antibiotic resistance is significant. It touches all antibiotic classes, and this has very serious consequences. And we've already discussed, indeed, the different numbers and the estimations in the future. And so, definitely, we know that something needs to be done about this. What are the mechanisms of resistance to antibiotics by bacteria? Well, we definitely have bacteria that can cause changes in the permeability of the cell wall. We also have bacteria that are going to have efflux pumps, which are going to be able to pump the antibiotic outside of the cytoplasm of the bacteria, and therefore the antibiotic will not be active where it should be. We can have antibiotics that are going to target the antibiotic target is going to be modified, and we also have inactivation of the antibiotic by enzymes like beta-lactamases. And so, as it was said earlier, the major driver of resistance is the consumption of antibiotics in Europe. And as was said earlier, unfortunately, Belgium is actually a very, big consumer of antibiotics, particularly in the ambulatory sector, but I think even in the hospital sector, we can do better. And so why is it that giving antibiotics causes resistance? Well, the antibiotics are going to cause a selective pressure on the bacteria. And so when you give an antibiotic, we are going to select the strains of bacteria that are resistant to the antibiotic. And then we're going to end up in the human being with an individual that is maybe colonized by this resistant bacteria. And these patients are then going to remain colonized with strains for up to 6 months or more. And then when we move into looking into the flow of multi-resistant bacteria in different ecosystems, we can see how these multi-drug bacteria actually circulate in between different systems. And so we have the community, who someone in the community might be hospitalized. And in the hospital, we know that we undergo more procedures. We're at greater risk of receiving antibiotics and even becoming colonized or infected by a multi-drug resistant bacteria. Then we're going to go to a revalidation center, a nursing home, and then maybe we're going to have visits from the community. Then we're going to travel. And at the same time, we also have contact with livestock, with pets. And as a human community, we also are going to generate waste. And so as it was said before, we're going to have multi-drug resistant bacteria that's going to be found in the sewage water. And so we're going to end up with different niches in the environment that are going to cause problems as in a general sense. Now, I would like to say that even if it's true that livestock do receive antibiotics and they can play a role in the antimicrobial resistance problem, I think it's important to know that the major cause of antimicrobial resistance in humans is really the antimicrobial consumption in human medicine. Now, I think that it's good to take a look at the epidemiological situation in Belgium. And as was said by Professor Vincent, we do not have such a problem with multi-resistant gram-positive bacteria today. As you can see on the left side, we have a graph of methicillin-resistant Staph aureus, invasive isolates, and as you can see in black, the line with the weighted average in Europe, and then the green line, which is numbers from Belgium. You can see that over time, we have less and less cases of invasive infections due to MRSA. However, when you look at the graph on the bottom, on the left bottom side, you see that actually in Europe, there's a significant increase over time since 2011 concerning Enterococcus faecium resistant to vancomycin. And I guess in Belgium, we are in a good situation, because even if at a certain time the numbers were increasing, we are once again in a situation where the numbers don't seem to be very alarming. And so I think that we do not need to worry as much about gram-positive infections. So we're going to be concentrating now more on the gram-negative infections. And so if we look above on the graph on the right upper side, this is a graph on E. coli invasive isolates that are resistant to third-generation cephalosporins, which are really already quite large-spectrum antibiotics. And so I guess here, when you look at this graph, you can see that over time, both in Europe and in Belgium, the percentage of isolates has a tendency to increase, although we can say that in Belgium, things look better than maybe when we compare the numbers to Europe. Now, on the graph on the bottom, we come to invasive isolates that are resistant to invasive isolates of Klebsiella pneumoniae that are resistant to carbapenems. And here, once again, we see that both in Europe and in Belgium, the percentage of isolates increases over time. And it's true that in Belgium, maybe we can say, okay, we're better off than other areas in Europe, but it's still going to be a problem. And so if we take a closer look at the situation, for example, with the resistance to carbapenems, I just wanted to insist on the fact that carbapenems for us are really the 4x4 antibiotics that should be able to treat almost any bacteria. And when we do not have carbapenems to be able to use and to treat these infections for severe infections, we are really left without many other options. And so it is very worrisome when you see that since 2009 to 2017, you see different countries in Europe that have changed color. And you see, for example, Greece, Italy, that really have become situations where there is a lot more carbapenem-resistant bacteria present. And so let's just talk about this resistance of Enterobacteriaceae to carbapenems. So I think it's important that we give two definitions. One, CRE, which are Enterobacteriaceae that are resistant to carbapenems. But we also have CPE, which are Enterobacteriaceae that are producers of carbapenemases. And so there are several mechanisms of resistance to Enterobacteriaceae, to carbapenems. We can either have a situation where there's a change in the permeability of the cell wall of the bacteria associated with an enzyme production. Usually, these isolates of bacteria are relatively unstable and not very virulent. But then we also have bacteria, Enterobacteriaceae, that are going to be producers of enzymes, of carbapenemases. And the big problem is that these genes to the carbapenemases can actually be propagated through plasmids from different species of gram-negative bacteria and also amongst the same species, and therefore propagate this resistance to many places. And so I think that it's interesting to look at, for example, the Klebsiella pneumoniae carbapenemase producer, which was first actually identified in 1996 in the USA. And At the time, there was a music group called New Kids on the Block, and I think that that's really what this bacteria was. It was a new kid on the block, and in a very short time, it actually, we observed international spread of this bacteria, and today it definitely causes a number of different problems. And it causes a number of different problems because we first can look at, actually talk about the enzymes. So the beta-lactamases are enzymes that are going to, as I said, cause a hydrolysis of the beta-lactam ring. And beta-lactams are really the most important antibiotics that we have to our disposition. They're not very toxic, and they're usually quite efficacious. When we look at these different, we can classify these beta-lactamases in function of their amino acid sequences. And so we can, they're either related to serine, there's a serine in their the place where the enzyme is active, and we can have either class A's, class C, and class D. And then we can also have metallo-beta lactamases, and these actually are enzymes that are going to need metal, such as zinc, to be able to be active, and this corresponds to what we call our class C beta-lactamases. And now when we look at these different classes of beta-lactamases, we actually know that we have different substrates that are going to be the optimal substrates to for these enzymes to destroy. And so we can see that there are different, so we have the class A's, and we also have the class B, and we have the class D that actually uses substrates such as carbapenems, and so that is why we call them carbapenemases. And so here we look at the carbapenemases that are actually some of the carbapeneses that are the most frequently found in the clinical situation. And this graph, what is the most important point of this graph, is to say that once we have a bacteria that produces carbapenemases, we really have very few antibiotics at to our disposition. These bacteria that produce carbapenemases are often resistant to fluoroquinolones, to cotrimoxazole, to chloramphenicol. It's true that we usually have a susceptibility to colistin, to fosfomycin, to tigecycline, but these antibiotics are actually antibiotics that are either have been revived or are truly not very efficacious to treat infections such as these infections due to very resistant gram-negative bacteria. And so I think it's interesting now to look at the situation in Belgium to see exactly what is happening over time concerning our Enterobacteriaceae isolates that produce carbapenemases. And as you can see, ever since about 2008, we began isolating CPE isolates. And over time, we've had increases. And ever since about 2014, the situation looks like it's relatively stable. We can also say that if we take a look to see if we receive isolates from laboratories all over Belgium, it is definitely the case, which means that the problem of CPEs are actually found all over Belgium, and they're not just isolates coming from one single laboratory. And so I think that's also an important point. Now, if you look at what kind of CPEs we find in Belgium, you can see that the number one leading CPE that we find is our OXA48s. And now, if we look at the epidemiological stages of CPEs in Europe, I think it's also interesting to see that Belgium is in bright red. And basically what that means is that we are in a situation where there's interregional transmission. And you just have to look to see that at around 2010, we only had sporadic cases in hospitals. And very quickly, ever since 2014, we've moved into a situation where we are clearly in an interregional spread of the CPEs. Obviously, there's other countries in Europe that are worse off, such as Italy, Greece, where the situation is just already declared as endemic. And so, is the near future a doomsday prophecy, or is there some light at the end of this tunnel? And so I think that I would like to now present to you several clinical cases, and this I think will allow you to understand what the job of an infectious disease specialist and microbiologist is in its daily life. And so here's our first case, a 70-year-old man who was transferred to Erasmus Hospital from a hospital in Italy after a 2-week stay for a cerebral hemorrhage due to an arteriovenous malformation. The patient arrived intubated, unconscious, and we had some information already concerning previous bacterial colonizations. As you see, he's transferred. We find out that he's already colonized by a very resistant Klebsiella pneumoniae, and it can be found in rectal swabs, tracheal aspirates, and urine. Unfortunately, literally upon arrival, the patient is in septic shock without any obvious infectious foci, and so catheters are changed because the catheters have been in place for more than 14 days. Microbiological samples are taken, and we start quite a cocktail of empirical antibiotic therapy. Now, we could ask ourselves, should we really be covering empirically or try to cover the treatment of this Klebsiella pneumoniae that was found to colonize this patient everywhere? And I think it's important to know that one of the major determinants of increased risk of multi-drug resistant infections in the ICU is truly previous colonization by multi-drug resistant bacteria. What you do have to know, though, is that the positive predictive value of having this determinant is only 50%. And as you will see, so you can also ask yourself, okay, if we decide to try to treat empirically this Klebsiella pneumoniae, should we be giving a monotherapy or should we really be giving a combination therapy to be more efficacious? And if you look into the literature, there are a number of different meta-analyses and systemic reviews on the subject. And one of the more recent reviews has actually studied 53 studies, and the primary outcome that they looked at was at mortality. And what they found was that actually it was much better to give combination therapy than monotherapy if we just look at mortality of the patient. But we have to admit that unfortunately the quality of evidence, even in 2019, is extremely poor. So let's say we chose to give the big cocktail of antibiotics, and to our great surprise, the next day the patient had 2 blood cultures that were actually positive for an Enterococcus faecalis ampicillin susceptible. So basically, and we also found on the central venous catheter that there were over 5,000 colonies of the same bacteria. And so we were able to conclude that the patient had had a catheter-related infection. The clinical evolution was very positive because the patient rapidly the septic shock resolved quickly, but the patient did develop an acute renal insufficiency, and this was definitely attributed to the septic shock, but also to the antibiotics that the patient had received, to vancomycin, to aminoglycosides, to colistin. And so for the treatment, we definitely stopped all of the unnecessary antibiotics, and we began a very focused antibiotic therapy for this patient. And so I think we can conclude that because the patient was colonized with a very resistant pathogen, and because he was in septic shock, we were obliged to do carpet bombing for a very severe infection due to a very susceptible pathogen. And so actually the patient had unnecessary exposure to a very large spectrum of antibiotics, and he suffered from increased toxicity because he did develop renal insufficiency. And definitely there were increased costs, not only due to the renal insufficiency, but to the number of antibiotics that we administered to this patient. The following case is actually the case of a 31-year-old female that was admitted to the ICU because she was victim of the terrorist attack in 2016. When she arrived, she was in hypovolemic shock. And what we are going to do very quickly is we're going to stabilize her. She's going to need abdominal surgery to remove a bolt from the pelvis. And she's also going to need mostly orthopedic surgery because she's going to have an open multifocal fracture of the left proximal femur. And it is this wound in the thigh that is going to be a problem as time goes on, because already on day 3, the patient is going to develop septic shock due to this the infected wound of the left thigh. Because this patient arrived from the outside, and it's true that she had been immediately put on amoxicillin clavulanate because of the open fracture. When she developed septic shock, we did as is recommended in our hospital. We increased the antibiotic spectrum, and we gave some aminoglycosides, and we performed surgical debridement of the wound. To our surprise, we found several bacteria in this wound, and what was to our surprise was that this patient already had an infection due to a Klebsiella pneumoniae that was extremely resistant. We basically had no beta-lactam that was active or against this Klebsiella pneumoniae, and you can see only in yellow and green antibiotics that had some kind of activity against this Klebsiella. And so in this situation, we actually were faced with inappropriate empiric antibiotic therapy. And although I agree that this is a simplified picture of what we need to do when people present septic shock, I think that it does illustrate well that when the infection is severe, we should be giving exactly empirical antibiotic therapy rapidly, and we should try to be appropriate. And so we are lucky, she will survive, and the only thing is that we will then be faced with an infection for whom there aren't many antibiotics available to treat her. And so because we are able to try to optimize different administration of antibiotics, because we know how different antibiotics are most efficacious, and because we are able to measure the serum concentrations of certain antibiotics, we are able to kind of individualize certain antibiotic treatments, and this is what we did. We had to do it for a very long time because her bone was infected. So as you can see, she received a whole cocktail of antibiotics from day 5 to day 70 of hospitalization in the ICU. And during this time, it wasn't only a very long treatment, but it also was a treatment that, needed very high dosage regimens, and sometimes we gave dosage regimens of very toxic drugs that were even 2 times the standard dose. And so the patient does leave the intensive care unit at around day 70. And then afterwards, we stop antibiotics for a while, but clearly she has pus that discharges from her fixators, and she has her left femur that will not consolidate. And so basically, we have the diagnosis of a chronic osteomyelitis, and when we take further biopsies and we try to do further debridement, we identify, once again, multiple bacteria, and particularly the Klebsiella pneumoniae, which has become more and more resistant, despite the fact that we have tried to give individualized treatment, and we have tried to really measure antibiotic concentrations, and we have also tried to give cocktails of treatment, and so combination therapy and not only monotherapy. And so this time, we really had to start thinking out of the box because this patient did not want to lose her leg, and we also still had a left femur that could not consolidate. And so we tried to think about what else we could do. And so this is where we went, and we thought of giving her phages. Phages are DNA or RNA viruses that infect bacteria. They do not infect human cells. And basically, what we knew from the literature that at the time was not very abundant, we knew that phages are species, but also strain-specific. And so we knew that we had to give a cocktail of multiple different phages. And the truth is that we didn't know what dose to give, how to give it, but nevertheless, we did move forward. It took a certain amount of time, and it took us until day 700 to be able to get the phages and identify phages that could be active against her bacteria. And we had someone from our hospital actually go to Georgia, to the Ilyava Institute, to go get the phages. And finally, we were able to administer these phages on day 702 after the terrorist attack. We combined this treatment with actually a new antibiotic cocktail, because at the time, ceftazidime avibactam had just gotten European EMA approval, and so we were able to obtain it by compassionate use. And we knew that our Klebsiella pneumoniae that we had found in this patient was actually susceptible to this drug. Because we were scared that we would have resistance occur very quickly, we did try to once again associate it to other antibiotics for which there was intermediate susceptibility. And so we gave high doses of tigecycline, but unfortunately the patient will develop very quickly an acute pancreatitis grade A, and so we will have to stop that antibiotic very quickly. Now, 3 months later, the patient actually will have consolidation of this left femur fracture. We're going to be able to remove the external fixator, and microbiological samples of her thigh will remain negative for the first time in the over 2 years' time that we were following her. And so this is just a picture of the before and after of her left leg. And now I'm just going to move on to our number 3 case before we come to conclusions. This time it's a 16-year-old male that's transferred from another institution for a left upper lobectomy for a pulmonary abscess due to a pan-resistant Pseudomonas aeruginosa. The medical history of this boy is a hemolytic anemia that was treated with immunosuppressors. The patient had been admitted 7 weeks earlier for a necrotizing pneumonia, and unfortunately, no pathogen had been identified upon admission. But 4 weeks after admission to the hospital, they did identify a multi-resistant Pseudomonas aeruginosa in the bronchoalveolar lavage. The patient had already received numerous antibiotics when he arrived to our hospital, and when he arrived, we had very little information on any kind of microbiology information. The last microbiological sample dated more than 2 weeks prior to his transfer. And so we actually had to go basically into surgery without really knowing how to optimize his antibiotic treatment. Nevertheless, very quickly, we're going to find out that the Pseudomonas aeruginosa found in his lung is basically resistant to all antibiotics except for colistin. And so we were desperate, and so we started testing for other antibiotics that were not available in Belgium, but were accepted by the EMA. And so we were able to find that we had the possibility of giving ceftolozane tazobactam, which basically is a new beta-lactam with a new beta-lactamase inhibitor. And we were able to find one study on this on this drug. It was a retrospective study on 21 patients where most of them had pulmonary infections. And we were quite happy because the article showed that there was about 70% success rate, but there were a couple of patients that actually developed resistance rather quickly after receiving the antibiotic. So we did the necessary to obtain the ceftolozane tazobactam for about 100 vials of this antibiotic. It cost 10,000 euros. This patient and his family were dependent on the CPAS, and so we also had to really make big efforts to try to find a way to pay for the antibiotics. And then the good news is that at first things went better after the patient was treated. Then he had to go to surgery because he had some leaks, air leaks, and so he actually had to undergo finally an upper lobectomy. And after going for the full pneumectomy, the patient actually developed an empyema this time. And what we're going to find is that it's an empyema that's due to, once again, Pseudomonas aeruginosa. And this time, even though we tried to make sure that we don't give the ceftolozane tazobactam in monotherapy, we gave it with other combinations, the patient had become resistant to the ceftolozane tazobactam. And so we once again, the child was 16 years old. We looked for other options, and so that's when we knew that there were clinical studies, phase 3 studies going on for cefiderocol, and we found that actually the Pseudomonas was active against this Pseudomonas that we had identified. Now, cefiderocol, is actually quite an interesting antibiotic because it actually uses iron pumps to be able to go across the membrane of the bacteria, and therefore the antibiotic arrives directly in the cytoplasm to be able to bind to penicillin-binding proteins, and so the antibiotic acts like a kind of a Trojan horse, and the results currently seem to be quite promising, and we were able to actually obtain this treatment for compassionate use for this patient. You have to know that the cefiderocol was actually accepted by the EMA now in April 2020. And so we actually have no more access to compassionate use of this antibiotic. And for 1 day of treatment, it now costs about almost 2,000 euros. And so the patient actually is, after we treat the patient with a cefiderocol and we drain the empyema, he's actually was able to be discharged from the hospital and he's doing well, but he did have to live with 5 months of hospitalization, and also he had to live with losing his left lung. So I would like to conclude that all of these cases actually illustrate several points concerning resistant gram-negative bacteria infections in Belgium, but also elsewhere. The acquisition of multi-drug resistant gram-negative bacteria is definitely a risk in hospitalized patients. Prior antibiotic treatment is also something that can certainly favor the emergence of resistance. The risk for subsequent infections due to these multi-drug resistant gram-negative bacteria is significantly higher for hospitalized patients with colonization than in patients without colonization. Patients colonized by multi-drug resistant gram-negative bacteria may nevertheless develop infections due to very susceptible bacteria, like our first clinical case. And the risk of giving inappropriate empiric antibiotic regimens is greater when there's an infection due to multi-drug resistant bacteria, because it's much harder to know exactly how we should cover the bacteria. And clearly, healthcare costs are significantly increased when there's an infection due to gram-negative bacteria, multi-drug resistant bacteria, because there's longer hospitalizations, longer treatments, and obviously the use of second to last line antibiotics. Patients are also exposed to significant antibiotic pressure because of the administration of many antibiotics and at high dosage regimens to try to treat these infections. Patients are at greater risk for adverse events due to antibiotics than patients who are treated for multi-susceptible pathogens. And so when we give aminoglycosides, especially when we repeat the administration of these drugs, we may have possible hearing loss, but actually we never send our patients that receive several days of aminoglycosides to have their hearing tested in a regular manner. We also for colistin in our patient that received in our very, very high doses of colistin, she clearly developed a renal tubulopathy. We also have renal insufficiency that is caused by colistin aminoglycosides. We had acute pancreatitis caused by high dose of tigecycline, and we also had cases of neutropenia due to high dose meropenem. We also have, as ID specialists, increased paperwork. So it is definitely paperwork to get the antibiotics through compassionate use programs, to be able to get actually access to phages at the time, and also things like cefiderocol. We have to go through the ethics committee. We have to make sure that we have a right to use the medication because, for example, cefiderocol wasn't yet approved by the EMA at the time. And definitely, if we need to worry about funding, we also have to worry about who's going to pay for the medications that we try to import or to bring in. And so these cases also illustrate the benefit and the need to work in a multidisciplinary fashion. So we need to collaborate, we need to think out of the box, and definitely we need to think about novel therapeutic approaches, new antibiotics. Now, in our case, the outcomes that I presented were actually positive for our patients. However, it is very difficult actually to determine in the cases of multi-drug resistant infections whether these positive outcomes were actually due to one specific intervention. And I think that a lot of the data and a lot of the articles on these kinds of infections is very difficult to read and to tease out what is the element that works the best, because many times we try to do many things at the same time, and at the end something works or it doesn't work. And despite combination therapy, bugs continue to get more resistant, and the risk of developing rapid resistance, even to the last line drugs, is truly a reality. And so I just want to also comment that there are many novel treatments for multi-drug resistant pathogens will still have to be demonstrated in the future, even if these antibiotics arrive to the market to treat these infections. So treating infections due to multi-drug resistant gram-negative bacteria is very challenging. There's a need for individualized treatments, and the optimal treatment for one patient with a multi-drug resistant gram-negative bacteria infection may not be the optimal one for another. And so it has already been said, but there's also a great importance for source control. When also treating these infections, it is important to take into account the patient, the severity of the infection, the site of the infection, the antibiogram, and even the enlarged antibiogram, and definitely everything that we can know about the pathogen. To do so, infectious disease specialists and microbiologists, so people who are knowledgeable in this domain, are really needed to treat these infections in an optimal fashion to ensure the best outcomes for our patients. And so I just wanted to say that there are two ways to deal with multi-drug resistant infections. So we can deal with it through prevention, such as hand hygiene, and also definitely by antibiotic stewardship. And I fully agree that antibiotics need our protection. However, I think that it's important to look at also the antibiotic consumption in acute hospitals in Belgium between 2013 and 2018. And basically, I would argue that there's no change, or very little, despite the fact that there are still that efforts have been made, but clearly more efforts will have to still be made. So there's also a second way to deal with these infections, and that's to find the magic bullet. But actually, there are very few antibiotics against gram-negative bacteria that have actually made it to the market in Belgium over the last 20 years. So I had a look to see exactly what was accepted or approved by the EMA over the last 20 years. And in yellow, you can see the medications that have not made it to Belgium, and 2 of those medications have just been EMA approved, so maybe they're going to make it, such as the cefiderocol, to Belgium in the future. But we definitely have, for example, doripenem. We also have and ceftolozane, tazobactam have not made it to the market. And as far as I know, Belgium hasn't even been approached to find out if we wanted to have these antibiotics available. And so that is, I think, just interesting to know. I think it's also nice to have treatments, but there's also a lot of efforts that need to be made in rapid diagnostic tests so that we can actually identify rapidly the patients that need special treatments or special antibiotics. And I think that there's work being done in this field, but we definitely need to move further forward. And I'm almost at the end. So I also wanted to say that there is no current nomenclature for ID specialists and microbiologists to bill for the time and efforts that they spend to try to treat difficult to treat infections, or to perform antibiotic stewardship, or to perform extended antibiograms, or to perform MIC determinations of the pathogens to allow for individualized, personalized therapy. As a result, the number of ID specialists and microbiologists per hospital is very limited because actually we do not bring money to hospitals in an upfront fashion. Yet without us, infectious complications of modern medicine cannot be managed in the most optimal fashion. So these small teams often cannot accomplish all that they should be doing on a day-to-day basis. So I think it is illusionary to believe that the epidemiological situation will get better without putting more resources into carrying out antibiotic stewardship, both in the hospital setting and both in ambulatory care. I also wanted to say that new antibiotic treatments also need financial support. To save a life, for a multi-drug resistant gram-negative bacteria infection, maybe it could cost 7 days of treatment times about 2,000 euros. So we're talking about 12,000, 14,000 euros. is that so expensive if we actually are able to then allow the patient to live many years afterwards, especially when you compare the costs of the last 6 months of cancer patients? And so I think that better financial solutions for the patients needing them, needing these new antibiotics, need to be found, because the ID physician can't spend his or her time running after money to pay for antibiotics that are not yet available in Belgium. And finally, I think that we are going to just finish with just the last slide. I think that nevertheless, there is good news. As it has been said before, there has been a recent official recognition of ID specialists and microbiologists, and we are very happy about that. Belgium has also decided to pursue the fight against antimicrobial resistance in a more active fashion, such as the elaboration of this National One Health AMR action plan, which I think is very important. And so instead of running or leaping alone, results will be better by working as a team and with support from all. Thank you.
Thank you, Maya. This was a really super nice talk. Allowing some time to Professor De Wolf to join us. I hope I pronounced correctly. I just would like to make 3 comments. The first is the expertise level of physicians, and I cannot avoid bridging physicians and healthcare managers with this topic. I mean, this topic helps us bridging people and bringing them together. So I imagined the work that infectious disease specialists do, but I am even more impressed when I see the cases that you showed us. The second remark I wanted to make is about the cost of drugs, and we definitely, as healthcare managers, we definitely worry about the cost of innovation. Innovation has a cost, and we have to work in partnership with the healthcare administration and with our government and ministers in order to create what is needed to finance that. And last but not least, I have to tell you that I have great hope in that new reform of the financing of physicians in hospitals can maybe bring an answer to your question. But that is a hope, and that is a close hope, because in the near future, maybe the future government will take some proposals we have done into account. And then to come to the next speaker, as you said, we share bacteria with animals, and of course coronavirus came from the bats, and then through the pangolin, and finally to humans. So maybe we should also never forget that it is the same place we live in. Professor De Wolf is from Ghent University and is founder and president of the AMCRA. So AMCRA is antimicrobial consumption and resistance in animals. So it's like the Babcock for animals. And sure, it's centre d'expertise, as we say, like the KCO. Please, Professor, share with us your knowledge and let us understand what we should do and not do.
Thank you very much, and thank you for this introduction. I'm certainly probably the strange guy in this audience as a veterinarian and not among human doctors, but I think already being here and being invited to this conference is a very good signal, because it means that we recognize this One Health issue, and we recognize indeed, as you introduced in the introduction, that we live on the same planet, and we share a lot of microorganisms together. And often the animals are there to be blamed if something goes wrong. And sometimes that's also the story when we talk about antimicrobial use and antimicrobial resistance. So I'm going to try to explain you what we've done in the last years in Belgium with regard to the antimicrobial use issue. And I'm trying to move. Okay. Okay, so I have this slide has been up several times, so I won't dwell on it, explaining you once more that it is a big threat, this antimicrobial resistance issue, and it's certainly a threat that has entered into the world of the veterinary sciences as well. So it's not that we have been blind for this threat. It is very widely discussed in veterinary medicine, among veterinary doctors, this risk. And we do live in a one world. We live in one world. We use antimicrobials in the community, in hospitals, as has been discussed before in great detail. And we also use them in animals. And when people think about animals and think about animals and antimicrobial usage, we are directed almost automatically towards the food-producing animals. The pigs and the poultry, the cattle, the animal industry is often called. However, we shouldn't forget, and indeed, there is a certain reason behind that. We have a lot of these food-producing animals, especially in a country as Belgium, and we are using antibiotics in them, but we're also using antibiotics in companion animals, something which is often overlooked. And when we think about companion animals, the relationship between humans and animals is much more intensive when we think about companion animals than when we think about food-producing animals. There's many more, almost 25% of the households in Belgium have at least one dog or one cat in the household, so 1/4 of the population is in daily contact and quite intensive contact with their animal. So when we're treating animals, also in companion animals, there is a risk of inducing resistance, and there is a risk of transfer of resistant bacteria from animals to humans. On the food-producing animal side, there's also, of course, there's more animals and there's bigger volumes, and there's bigger volumes of antimicrobial usage. And there, of course, we are consuming the products. But I was very happily surprised with the statement made by the previous presenter that although sometimes the veterinarians and the food-producing animals are blamed for a lot of things going wrong, it's very clear now with recent research that we cannot state that a lot of antimicrobial resistance is coming from food-producing animals. The best way of transmitting bacteria from animals to humans is by direct contact, and we do not have so much direct contact with food-producing animals, except for veterinarians or farmers really working in close contact with them. But we do see that there is a complex interaction between all these animals and humans, and so we have to take that into account. We also have to take into account that antimicrobial usage leads to antimicrobial resistance. Was shown in the previous presentations, and that's exactly the same in veterinary medicine. When we use a lot of antimicrobials, we get a lot of resistance. And this is only one result of a study we've done already several years ago, where we looked at publicly available data with regard to antimicrobial usage in animals and with regard to antimicrobial resistance in animals. And then, unfortunately, we see that our own country, Belgium, is quite on top of the list in terms of a lot of usage, translated in a high ranking with regard to resistance in bacteria we find in animals. Countries that have a long tradition of a low usage in animals also have a low level of resistance. So that is certainly something we have to be aware of. However, note that we only have 7 countries here on the list, and of course there's many more. Those were, in 2012, when we did the study, the only 7 countries in the world where we had good data both on usage and resistance levels in animals. Today, we have more countries and we have more data in these countries, and certainly Belgium is no longer on top of the list. We're not the worst student in the class, for sure. So, another thing is that, okay, when we look at antimicrobial usage, and this is maybe a little bit small, but when we look at the amount of antimicrobials that are used in humans and animals, in terms of days animals are treated a year, or humans are treated a year, we have almost like a comparable use. If we quantify it in terms of kilograms or tons, whatever you want to use, of active substance of antibiotics, in Belgium, a much bigger volume of antibiotics will go into animals than will go into in humans. Why is that? That's simply because we have much more animals. We slaughter around 11 million pigs a year in Belgium. We slaughter around 400 million of broilers, of chickens a year in Belgium. We have a huge population of cattle. So there's simply more animals than there are humans, and that's why we use more antibiotics in absolute volume. These data in the past have sometimes been abused to claim that veterinary sciences or veterinary medicine is the major source of resistant bacteria. But as I said before, and I was also said by previous presenters, that's not the case. Nonetheless, we do not claim that we have nothing to do with it. I said there is a One Health issue, so what we do in animals has an impact on humans, exactly as what you are doing in humans has an impact on animals. So we're simply sharing these microorganisms. So what do we do about it? What do we try to do to improve the situation in the veterinary sciences? Well, as I mentioned, uses leads to resistance, so the solution is in trying to reduce the usage. And to be able to do so, you need to measure. That is quite obvious. We need to be able to measure the usage. And to do so, we have developed in the veterinary world the BelVetSac surveillance system. It's the Belgian veterinary surveillance of antimicrobial consumption, collecting data on antimicrobial usage annually. And this is it's piloted by the Medicines Agency, and we do it together with Kent University. So Kent University is executing the work in on demand of the Medicines Agency, and we collect data on antimicrobial usage from the distributors of the antimicrobials and from the feed producers, because sometimes antimicrobials can also be mixed into the feed of animals, and that's specifically the case in pigs. And we started with doing that in the year 2009, and we went back a couple of years and up to 2010, and we saw a gradual reduction in usage, but it was not very satisfying. And still we had very high levels of antimicrobial usage in animals. So actually these data, these first data, and it's always good to have data because then you can objectivize the discussions. These data started or sparked the development of AMCRA. As you mentioned, the Center of Expertise on Antimicrobial Consumption and Resistance in Animals. And AMCRA is actually the place where we gather all the stakeholders. So in AMCRA, we have the veterinarians, but we also have the farmers' unions in there. We have the feed producers, as they all play an important role. We have the scientific world in AMCRA, and we even have the pharmaceutical industry in the board of AMCRA, for which we are often approached, and people hardly understand why we have pharmaceutical industry, but the goal really was to have everybody on board, everybody on the table, and to move together towards strong and ambitious improvements. And ever since, we are established in 2012, the 1st of January 2012, we start working with AMCRA. And ever since, all these stakeholders are still in AMCRA, and we have produced quite good results. So the goal is really to go together. Sometimes it means that we can go as fast as we would like to go, or at least if we as scientists would like to go, but it is a quite sustainable improvement. So how is AMCRA constituted? I won't dwell on it, it's not so important, but it's just to say that AMCRA is an independent organization with a steering committee consisting by the government. So the government, the food agency, the medicines agency, and the Volksgezondheid, I don't know the English word, they
BASF.
are, okay, well, so they are steering the activities of AMCA. They're also financing, not entirely, but to a large part they are financing our activities. And then it's the stakeholders that are really doing the actions, and we have some staff working in AMCA. Not a very big staff, but still a very active staff, I would say. And with this group, independent from the government, with the stakeholders themselves sitting around the table and discussing, we've came up with these goals. And these quantitative goals are really what drives us every day. We really want, and we have stated in 2014 when we came out with these goals, by 2020 we want to reduce the antimicrobial use in animals with 50%. So not a slight reduction, but really we want to halve the amount of antimicrobials we're using in animals. The antimicrobials, critical antimicrobials, and then I talk about the use of the fluoroquinolones in animals and the use of the third and fourth generation of cephalosporins in animals. For clarity, carbapenems are not used at all in animals, so they are of course also critical, but they do not involve veterinary sciences. But for the others, the fluoroquinolones and the cephalosporins, we aimed at reducing with 75% by 2020. And then the use in the feed, the medicated feed, which is often a preventive use of antibiotics, had to be reduced by 50% in 2017. So let's see what we achieved. Well, this is the data, the last presented data up to 2019, so 2020 is still ongoing. And here you can see that last year we reduced with 7.6%, but you can see that there is a gradual reduction over the years since 2012 when we started with AMCA. We have reduced in the meantime with 40%. Remember, our goal was to reduce with 50%, so there is still a step to take, still a bit to go, but we can be already relatively proud about this result. So in 7 years, we have reduced the usage of antibiotics in animals with over 40%. And this is corrected for the size of the population. So this is milligram per kilogram biomass, so this is not due to a reduction of number of animals or number of production, whatever. This is really a corrected a number. We have also looked in detail in what antimicrobials, because criticists or critical people, which is always good, could say, well, a reduction in volume doesn't mean anything because you just shifted from one antimicrobial to another, from an antimicrobial with a heavy molecular weight to an antimicrobial with a lower molecular weight. But that is not what we've done. So we've looked at every different type of antimicrobial, and you see across the board that we have, for the majority of the antimicrobials, we have continuous reductions. There are a few exceptions, and these are really wanted increases, because those ones that are exceptions are typically narrow spectrum antimicrobials, and there where we try to move from the use of broad spectrum antimicrobials to the use of narrow spectrum antimicrobials, and then it's of course quite logical that these groups of antimicrobials will increase a little bit. But what is also important, I think, for the human medicine to understand is that we, for instance, the polymyxins, the colistin, which was mentioned several times in the previous presentation as a absolutely last resort antimicrobial, which we have been using in veterinary sciences for a long time, in veterinary medicine for a long time, with good results. Nevertheless, we have decided, based upon the risk, not because there is an issue in veterinary medicine, but because we know that it's a last resort antimicrobial for human medicine, we have decided to take actions to reduce the use of colistin. And for instance, since 2012, we have reduced the use of polymyxins with around 66% already, and we will continue to do so, and we will further reduce this usage. We have grouped our antimicrobials in different classes, the yellow, the orange and the red antimicrobials, and this is linked to the spectrum of the antibiotics. Obviously the yellow antibiotics are the narrow spectrum, the orange are in between, and the red antibiotics are those critical ones I've mentioned before, the fluoroquinolones and the third, fourth generation cephalosporins. And we're also following up what is the shift in the different types of antimicrobials, and across the board we see a reduction in all the types. We would even like to see more reduction in the red ones and in the orange ones, so there is still some work to be done on that side. So let's see what the goals are. Since we want to reduce the use of the red molecules, those most critical important ones with 75%, well, in 2019 we are already at 77.3%. So we have very, very drastically reduced this use, and typically between 2015 and 2017 this has reduced enormously, and this is due to the introduction of specific legislation which was implemented by the government on request of AMCRA, or in collaboration with, but also on request. We asked the government to introduce legislation which was agreed upon with the veterinarians, with the farmers' unions, and that legislation has helped enormously to reduce the use. Ever since, there is a slight increase, and this is worrisome, and this is something we are currently working very hard. We know where it is. This is linked to the poultry industry. This is linked to a very specific situation in the poultry industry, but we're currently working on it to reduce it again. So this goal was achieved. The second goal with reduction of the use of antibiotics in the feed, and also here I want to specify, as sometimes people still believe that in veterinary medicine or in animal production we are using antibiotics for growth promotion, to improve the gut or to improve the growth. This is not true. It was true until 2006, but this is an activity which has been forbidden in the entire European Union since 2006, so it's not done anymore. It's still done in US, it's still done in some Asian countries, African countries, but in Europe we don't do that anymore. Still, sometimes we mix antibiotics in the feed as a treatment, and that's the type of treatment we also want to get rid of, specifically because it's often a preventive treatment. So here we wanted to reduce with 50% by 2017. Well, we have already reduced with 71%. So also this goal has been achieved, and actually it was achieved earlier than what we aimed for. And then finally, our global goal at the reduction of the total use. There is still 1 year to go, as I said. I'm not sure whether we achieved the 50% exactly on time. Maybe we'll need a little bit more time to get there, but if you see the line, if you see the direction of our actions, you can clearly believe that we are going in the good direction. Where are we with regard to our colleagues in Europe? And that was also already presented by Martine Delanoë. Still, Belgium is at the side of the higher users. We used to be in the really high users, but we have reduced already quite a bit. But still, to our feeling, we are too much to the left in this on this slide. We are too much in the area of the high users, and we really want to go further down, and we want to get into the average use of antimicrobials in animals here. So how are we going to do that? Well, for the future, 2020 is already today, so we have introduced new goals, and those new goals are also linked to the National Action Plan, and they're also introduced in the National Action Plan. We are currently establishing usage guidelines and also maximum usage limits for the different animal species. So for every animal species, we will determine what is a normal use and what is then, of course, an abnormal use or too high use, with some action values. And every farm, and I'll talk about that within a few minutes, every farm has a report, receives 2 times a year a report on its use, and every farmer will be able to see where he or she is in terms of the level of antimicrobial usage and whether he or she has to reduce this usage. And that's for cattle, for pigs, for poultry, and so on. And this should lead us, and you recognize maybe this graph again of the different European countries, this should lead us to a further reduction of our usage in animals with another 15%, bringing us together in total of a reduction of 65%. And remember that our original goal was 50%, and with all stakeholders involved, we agreed that we want to take another step and we want to go to 65% reduction in comparison to 2011. And if we achieve this, then we will really end up in the average population in Europe and the median value of Europe, which is, I think, a quite normal antimicrobial usage. So that is still a big task ahead, but we're quite confident that we will achieve that. Cholesterol, I talked about it before. Also there, we want to go further down, and we want to go to less than 1 milligram per kilogram biomass. And then again, we are in the best countries of Europe, because that is also the goal set by the European Commission to be below this level of 1 milligram per kilogram. And we want to further reduce the use of antibiotics in the feed with 75%. So the first goal was 50%, and here we want to go up to 75%. So you see, we have ambitious goals. We have already nice results to present, but we want to go a lot further. And how are we doing this? And I've tried to emphasize it in my presentation by collaborating. Collaborating with all the stakeholders, but also collaborating with the government. And we really have a good collaboration with the governments that are responsible, and we work on co-regulation. And we try to do a number of things ourselves by the sectors, but we also ask the support of the government in terms of making legislation when it's needed, or to do take other measures to go together towards our goals. All of this is also translated in reduction in levels of resistance, because we of course are monitoring the resistance levels in animals. In some animal species, look at the chickens, for instance, they are still high. Also the veal calves, so the levels of resistance are still quite high, but we are moving towards in the good direction. This is typically for the ESBL resistance, where also we see some important reductions due to the reduction in the use of the cephalosporins, likely. So how did we get there? What did we do to achieve all this? Well, we did a lot of communication and sensibilization with small movies, with posters, with folders, with a lot of presentations, going into the field, presentations for veterinarians, but also a lot of presentations for farmers, because farmers and veterinarians have to be addressed in this. In the future, we also will address much more the owners of companion animals, so which is more the general public, actually. And we also we didn't only address the total use of antimicrobials, we also looked at antimicrobial treatment regimes. How long should we treat? Because often in veterinary sciences we still have the tradition to treat our animals too long. And so we have reduced, or still ongoing, and try to reduce the length of the treatments, and also optimize the dosages, the choice of the antimicrobials, and also the administration route, because we use with antibiotics in the water, in the feed, injections, and so on. And so also there is a lot of improvements to be made. We have developed these formularias, the guidance for all the different animal species. That's our one of the difficulties in veterinary science. Of course, we don't have one species; we have multiple species with all different types of diseases and different types of problems. But for all of them, we have developed guidelines on good therapeutic treatments, and they are available online. But I think the masterpiece of what we've did is this. We have developed a data collection system and benchmarking system for every farm in Belgium and for every veterinarian in Belgium working in food-producing animals. So every farm in Belgium, every farmer in Belgium receives at least 2 times a year a report on their specific antimicrobial usage on their farm, and showing them where they are and if they have to take actions in terms of reducing usage. And so we are producing around 40,000 reports a year with AMCRA, sending those to these farmers. And they get their report 3 months after the end of the period. So at the end of 2012, well, in March in March of 2021, they will get a report on the use of 2020. And so we are quite active and reactive, and we use these data to benchmark the farmers and to work on in terms of reduction. We have many other actions that we are working on. It's not only about measuring, but you have to translate the measures into actions, and there's many different actions that we are taking. And a lot of these actions are very comparable to what is done in human medicine. It's about infection prevention, it's about education, it's about monitoring of your resistance levels, and so on. So in that sense, we are absolutely not different from what is done in human medicine. I think the goal is prevention. If we can avoid the need of the use, and that's really our anthem, and that's really what we try to do. We try to avoid the need of the use, and by doing so, we can reduce the use a lot, and we can also reduce the resistance. And it's a long action. It's something when you start on this work, we've started almost 10 years ago, and we not yet at the end, but we will continue to move forward. Thank you very much.
Thank you. This was really a nice talk. I am really impressed with the results. I don't know, maybe I can hope that we achieve the same with our physicians, especially the ones outside hospitals, because I've been in the work group which was following with benchmarks and indicators, but we didn't really make those results. Well, thank you again. Maybe I'm gonna go through the questions and answers with everyone. Yes, please. And if you have questions, please feel free to maybe. Can we give them a microphone if they have a question between themselves? I have one question from the public, and it goes over the financing of the lab needs in hospitals. And he says, or she says, I don't know, that investment needs to be done in the labs, and sometimes even though money is spent, it could be like it could be beneficial at the long term. So due to silo thinking, these actions do not take place. I guess this is a question that goes. This is a question that concerns the system, the whole system. We work in silos, and we heard Professor De Wolf saying that they achieved their what the aims that they had through partnership and working together. And also Professor Hites said that it is a group work in hospitals in order to achieve correct response to patients infected. So this is my answer to these questions. I don't have any more questions from the public, so maybe if you have questions, feel free to ask them.
If I may, I would like to react on this question, because it's a point also that has been mentioned during the presentation. For instance, the procalcitonin that does not benefit yet in Belgium from reimbursement. And it's one of the points that has been discussed during the preparation of the National Action Plan. And so we have to take a little bit of time to see how it's going to be organized. But in the actions also that have been presented by Martine Delannoy, just before we had improvement in the availability of medicines on the Belgian market, but there is also in the same along the same line improve the availability and the accessibility to diagnostic tests. And it's true for the ambulatory care, point of care. The GP, the general practitioner, can easily identify whether it's a bacterial infection or not, viral, so antibiotics are not needed when the clinical situation does not indicate for complication or something like that. But it's true also indeed for the hospital that some tests can facilitate and make quicker the identification of an infection due to multi-resistant organisms, for instance. So it's not yet solved, but we are very well aware of this kind of problem, and it's being discussed, and we try to put into implementation these kind of aspects.
Thank you, Anne. Well, as Professor De Wolf said, the actions they took in order to achieve what they achieved was communication, legislation, and benchmarking. And this is what we're doing here. I mean, communication. So we are trying to bring some information to healthcare managers who are not really on the terrain, you know, in the care of patients. But they need to understand what's happening and how their engagement can help practitioners to resolve these issues. I also know that this interaction with FPS in English, Federal Public Service, is also important in order to promote these actions. I have a question, so I'll begin like a few questions for each of you to Professor De Wolf. You said legislation helped a lot. Do you feel this can be done for physicians in the human sector, let's say, if legislation can help pushing some objectives we need to aim to?
That's a difficult question for a veterinarian, and actually I cannot answer on that because I don't know the field well enough. And in the past, I've had a lot of frustrations about human doctors talking about veterinary sciences with lack of knowledge, and I will not make the same mistake. So that's why I cannot answer. What I can say is that if you introduce legislation, that it's good to make sure that the legislation is supported by the ones that will be impacted by the legislation. And that is also what we've done in veterinary sciences. The government has introduced legislation, but it was done in collaboration and in agreement with the sectors. And then the impact of the legislation is probably going to be much better.
So I got the message. The message is legislation which can help to go towards the objective. Professor Vincent, I know you're fond of the idea of having less usual beds and more intensive care beds in hospitals. And of course, time gave you a reason. I mean, what we lived with COVID was truly this. But you also spoke about not the bacteria killing people, but the reaction of the body. And we are also seeing this with COVID, with inflammation and not really the virus. You also spoke about people dying from bacteria, but sometimes from other pathologies. Do you think we are dealing in a correct manner with COVID in Belgium?
My answer is neither yes or no. I think that, and I hope that people do their best, and I think that people have done their best, but the crisis has been very, very complicated. What we could have done, and Dr. Maya will agree with me, is to be better organized in our clinical trials, because we could have enrolled more patients in clinical trials around the globe this is not a Belgian story, but a global story. The WHO, the World Health Organization, tried to organize prospective randomized control trials, but they did not succeed very well because they are not prepared for that. They have never really done it in the past. But eventually, we learned, hopefully primarily from our UK colleagues, that corticosteroids, dexamethasone in particular, can significantly reduce mortality. This was discussed, we just have our big symposium right now with more than 5,000 people attending the discussions, and we had a discussion on corticosteroids early this afternoon, emphasizing the need to give dexamethasone in patients who are coming to the hospital in severe cases. But besides that, there was also this story of hydroxychloroquine that made clinical trials very complicated because many people wanted to receive that particular substance, either the patient himself or herself or the relatives. Oh, no, please give it. We're not sure it works, but who knows, give it. And so we could not randomize patients to study hydroxychloroquine adequately. And it took time to demonstrate that it doesn't work at all. Now it's well established, and this treatment should be abundant because unfortunately it doesn't work. But this prevented the conduct of good prospective randomized control trials because there are a lot of things that could be tested, you know, going even to female hormones because it seems that women have a better prognosis than men, right, when they are hospitalized with several cases. So there are some experimental data showing that female hormones can be, estrogens in particular, can be protective. And of course now we are excited with the antibodies to the virus, but we need to do the studies, and it will take some time. So there are a number of options. In Belgium, we have not been bad, but we have not been very good either. And of course, when we were very ready to conduct these trials, I am, helping the KCE with this. We had another meeting yesterday, but we realized that we have very few patients nowadays in our hospitals. So we cannot enroll patients in these trials because, fortunately, there are not so many bad cases at the present time. But for the clinical trials, it's unfortunate because we cannot make much progress with new therapies. So it's a very complicated story, but we have not been too bad. We have not been excellent either.
Thank you. My next question goes to Martine Delannoy. You can answer in French, of course, or English, as you wish. You talked about the data-driven, the data we are taking, the information needed to monitor, and do you really, do you think that we can keep this cohesion in our health system to keep all this data in the same place and avoid all this work that has been done in order to coordinate people? Like we are bringing together people we separated, and now we need to bring them together to work and to put it in practice, to put to work our plan, our national action plan. What's your feeling about that? Is it easier now, or was it easier before?
Thank you. Yes, it's a difficult question. I think it's a broad question. Yes, you have different type of data.
Yes, because we are living this.
Yes,
it was theory, and now it's like we are living this with COVID. We have different data coming from different parts of the country, and data is it takes time. So people are afraid of what's happening in our health system, and a lot of people have seen a lack of efficiency. And as you have just shown us, efficiency comes from data collection, from benchmarking, and from bringing people to work together. So is it something you feel is important more than it was before the COVID period?
It was already important, and it's still important. And what we have to reach is efficiency, like you said. So we have the new technologies, so the data can be, I mean, it can go easy, but it has to be optimized to be easy. Because I heard from a lot of hospitals that it was very a huge amount of time for some types of data, and sometimes also that they didn't see what were the results of this data, or the data came too late back to them, and that's not what we want. What we want is having efficient data that can help us to take measures, efficient measures, and to follow up the results of all of our actions. And that's what we are trying to do. And we do great work with Sensano, who has also a big role in this data management. And really, we don't say we need more data, we say we need maybe better data, and that's really useful with a fast feedback to hospitals or other doctors. And for that, we had a lot of discussions also with the sector of animal health, because in their sector, because there are other types of data, but like the feedbacks are much faster given back to the practitioners. And we learned a lot together, all the people together. And so that's really the aim, to have efficient data. And I think my colleague would like to add something.
I would ask the same question to Anne Ingenblick. And I'll have another small question also for you.
Okay, thank you. Yes, I think it's a very, very important point, data. In Belgium, it has been said in the several evaluation and analysis that we spoke about previously, we have a lot of data, but the connection between the data is not always done, or the capacity to develop this data into indicators that really mean something is not fully developed also. And so it's also part of our reflection which indicator we can use at which level. For instance, we have indicators that are useful for the general public, like the volume of antibiotics we are using globally, the compliance to hand hygiene, for instance. It's figures that is really directed toward the large public, or a macro, what we would say, a macro analysis. But then, as for instance, medical directors, director of hospitals, it's very also important to have your role, to have your play into this challenge, because the data are used also at the very local level. I liked very much during the presentation of Professor Vincent, before he said, in our units, we are doing this and that, and he can say, for instance, we have 43% of cases where we can de-escalate. That means that the data have been used really at the very local level, and they know they can lean on what they are measuring to improve continuously their care. And this data is used within the hospital, inside the hospital, but they publish them. So it's useful also to other teams. So by data-driven hospital, which we are presented in the 4 strategic axes at the beginning, this is exactly what it means, to be using the good data at the good level, to understand how to make them part of the improvement, and I think it's also very important to keep this triangle between the very field, the people dealing every day with the patient, the clinical aspects, with the hospital directors. Because it's a relay, and the beleid, as we would say in Dutch, the policy level, the policy for the national level. This is really what we can also do with data, is to link these 3 levels and to together reach a common goal.
Well, we are convinced as managers about the need of data. Data usage, but also data collection, data sharing, because a lot of people are afraid of sharing their own data. Of course, GDPR and other regulations must be respected, but data is something we push into sharing and using. But there is something else we really like to speak about and to help and to push forward is innovation. And that's my question to Dr. Ites. Of course, it's complicated being an infectious disease physician in Belgium, as the system is a fee. How do you say it? It's a fee for prestation. It's a pay for service, pay per service. So I understand it's difficult for you, but care of patients is changing. New drugs can save lives. We see it in cancer. We see it in infections. Do you think that physicians' mindset can help in bringing innovation, even if it can take some part of their, let's say, the budget? Are they ready for that? Are they ready to go, as we have also heard, in some new culture of quality around the work they are doing? Of course, I'm a physician, but I'm asking you this really bad, not a bad bug, but a bad question.
I think that's a tough question to answer. I think I can answer it as an ID specialist. Mm-hmm. And I think already as an ID specialist, even if you work in the private sector, usually you're actually being paid by a pool of the hospital, because it's not you bringing really a lot of money to the hospital in itself. So you're actually being, and so people are investing in you to help pay either for preventive measure, prophylactic antibiotics to help give recommendations, to take care of the patients that get infections after the surgeries and things like that. And so I think already ID doctors are maybe a little bit different, because I think we don't even in the Belgian sector have the opportunity or possibility to earn a lot of money in the private sector. And so I think that already we're in a sector where we are transversal, we work in all the domains, we realize the importance of prevention. And so I think that definitely as an ID specialist, I say yes, I think that very much in favor of having indicators and trying to work in that way, as long as the indicators, as it's possible to, as long as we have the tools to reach the indicators. So, I mean, we can talk about antibiotic stewardship, and it's true that hospitals do touch a lump of money every year that is supposed to be given, or that is given to the group of gestion des antibiotiques. And things are done in every hospital, and maybe things are done differently, but it's still not a lot of money to be really doing antibiotic stewardship in a really complete manner. And so it's just kind of doing patchwork on jobs that can really take extensive number of hours to do correctly. And so I think that if the tools are given to really do the things that we try to reach, then I think that then it's great to have quality indicators, and I think that people can be motivated to try to reach them. I think that if you set quality indicators that actually it's almost impossible to be able to reach the indicators with the number of people working in that domain, then I think it's just a source of frustration and a lot of pressure that you know that you're not going to be able to reach. And then when you talk about other doctors, I have a difficult time saying what people, I would hope so, as being a physician myself, that people, above all, I think that the patient is the center of care. And so I think that many physicians do believe that and are mostly interested with how, at the end of the day, we can do better in taking care of the patient. But I think that that's maybe what, anyways, I would hope that is true for physicians.
Thank you, Maya. I wanted to end with this, coming back to quality and speaking about quality. So pay for performance and quality measures are not yet I mean, the road to that is still maybe long, but we have seen that at AMCRA you have done it. So maybe in sharing and communicating and working together, we would be able to achieve this, and that's the hope, I suppose, of the Federal Public Service also. I would like to thank you all for being here, and Professor Vincent, especially because I just forgot and realized that it was the week of the symposium in Brussels. So really thank you for being with us, and each one of you, because you took a lot of time, and thank you to BD of allowing us being here, and that would be the end of our study day and our webinar, and maybe we would do it again, because I found that this presence and video conference is also a good way of working in the future. Thank you, everyone.